Good morning, everybody. I welcome you all to AIRCON 2026. AIRCON, this term which was coined by Jagruti Sanghvi, and every one of us said, yes, this is the best term, air condition in our city and probably the whole of the country. We all, as pulmonologists, are worried about that, and I thought AIRCON was a good name to give to a conference of this magnitude. I thank Mumbai branch IIP, the whole team from Dr. Kasla, Dr. Shikha, and Dr. Jagruti, who has stood by us to do this conference. And without them, I don't think this conference would have seen the light of day. And Dr. Udaipai, who's the thought, all thoughts come from Dr. Udaipai's brain. And then we have to humbly follow him and get the thing done, because his thoughts are always great. We have Dr. Sushma Save with us, who's our incoming president. We have Dr. Jayan Joshi with us, who's the president of the respiratory chapter of Indian Academy of Pediatrics. We have Dr. Rawat, who is just the past president of Indian Academy of Pediatrics. I welcome you all, and it's my honor to have you here. And we have Dr. Jagdish Goyal, who's also been the office bearer of the Indian Academy of Pediatrics respiratory chapter. Thank you all for coming here. No conference or maybe no activity can be done without, taking the name of the Almighty. But the Almighty is above, the Lord Saraswati. But I have a lot of Saraswatis here today, maybe avatars of Saraswati, who are going to impart knowledge to one and all. And I look forward to learning from each one of them. May I request our faculty and office bearers to come here. Dr. Kasla, our president. Dr. Shikha, our secretary. We also call her Singham. Dr. Jagruti, who's been very large-hearted in clearing your finances, so all your comfort is thanks to her. Dr. Sushma Save, our incoming president. Dr. Rawat, past president, respiratory chapter. Dr. Jagdish Goyal. Dr. Subhashish, a faculty from Calcutta. Dr. Rashmi Kapoor, all the way from Kanpur. Dr. Shilpa Hazare, she hosted the last Respicon. Doctors, and this is, yes, I'm calling, sorry. Sorry if I'm not a very office bearer person, and sometimes I make mistakes, so please pardon me. Dr. Bafna, Dr. Udaipai, Dr. Ruchi Nanavati, and the person who I take the name last, because we all draw inspiration from her, is Dr. Nehal, please. Dr. Ajit Gajendra Gadkar, faculty, please come. All the faculties I want here, because these are our, the Lord Saraswati is above, but these are the ones who are going to impart knowledge to us, and without them, I don't think we would be anywhere. I hope I have not left any faculty who's here and not come here. Okay, we can play the Saraswati Vandana, please. And we'll finish them and then put the lighting, or you want to start putting the lighting? Can I request you to light a digital lamp for us, because in the auditorium it's not allowed. So, yeah, you can play the Saraswati Vandana, please.
Saraswati namastu
I now invite Dr. Rajesh Kasla, President Mumbai Branch IAP, to say a few words before we start the conference. And after Dr. Kasla, I request Dr. Tanvi to take over. Thank you.
Good morning, everyone. And it is really a pleasure to see so many familiar faces here. On behalf of Indian Academy of Pediatrics, Mumbai, I welcome you all to NHSRCC Hospital for AIRCON 2026. This 2 days conference, yesterday we had 3 successful workshops, 2 here at SRCC Hospital on advanced bronchoscopy and radiology, and 1 workshop we had at Nanavati Hospital on allergy and skin prick testing. And these 3 workshops were really well attended. It was really successful. And I welcome you all to today's AIRCON 2026. When we chose this theme, Advancing Respiratory Care for Every Child, we were not looking for a slogan, but we were thinking of that child who comes to us with persistent wheeze in the middle of the night, with anxious parents, and pressurizing us that nebulizer ka or extra dose de do, heavier dose de do. And sometimes we really wonder, okay, what is this diagnostic dilemma? Are we, well equipped enough to answer all their queries? So today, it isn't about the didactic lectures. It is about getting the clarity on all these small things. Our scientific program is crafted from the 4 R's of rapid breathing in infants to the 4 C's of the chronic lung diseases in the pediatric age group. Here we are to bridge the gaps that is there mentioned in the textbooks to actually what happens in our Mumbai clinics. I want to really thank all the scientific committee, as well as all the pulmonary fellows, Dr. Tanvi and Dr. Abhinaya, who has worked tirelessly to change this concept to a vibrant conference today. Thank you very much. To our faculty who have traveled all across the states to share their expertise, and of course to the delegates who have come here and showed, it's a testament that in spite of the busy practice and the schedule, the child health comes first. So friends, let's be all interactive today. Let us ask curious questions and let us challenge those controversies, and most importantly, let's enjoy the process of learning together. With that, I hand over the mic to Dr. Tanvi. Have a wonderful conference. Thank you very much.
Thank you, sir. And at the onset, I'd like to welcome all of you here. As sir said, that the entire organization's tireless efforts and have pushed us into helping bring all of these amazing cases, panel discussions here to enhance everyone's knowledge on this Sunday. Thank you for taking out time on your long weekend. I know it's Gudi Padwa Eid and a long weekend for being here today and enhancing the day and enhancing the program. Without further ado, I would like to welcome our first session for the day, our panel discussion on the 4 R's, which is the rapid breathing in infancy, the red flags, reasoning and real world practice. As sir said, it's not going to be didactic. They're going to be interactive sessions, panel discussions with practical case scenarios and a to and fro. The moderator for this session is Dr. Subhashish. Dr. Subhashish sir, while he's extremely knowledgeable, sir's radiology prowess and so sir's sense of humor, I think, is what I remember from him. And sir will moderate this session, and our expert panelists for this are Dr. Jagdish Goyal sir, who is professor and in charge pediatric pulmonology AIIMS Jodhpur, Dr. Ruchi Nanavati, former professor and head Department of Neonatology. Change nahi ho raha hai yahan pe. Dr. Ruchi Nanavati ma'am, who is the former neonatology head from KEM Hospital. Dr. Shilpa Hazare ma'am, who is from Dr. Shilpa Hazare ma'am, who, as Indu ma'am rightly introduced, had organized Ped Pulmocon from the IAP this year, and Dr. Sanjay Bafna sir from Bharati Vidyapith, Pune. I welcome all the panelists onto stage. And one only thing is that we would like to keep to time today. We have too much knowledge to share, but unfortunately, people have flights in the evening, and we want to cramp as much knowledge as we can in a limited time. So I welcome everyone onto stage. Thank you. Outside, we have a very interesting, very expertly crafted radiology quiz, a little twist on practical scenarios, and it will be very interesting to solve the answers. The quiz is going to be displayed only till the lunch break, that is till the end of the lunch break at 1:40, after which the discussion will happen in the last session of the day. There is a drop box kept at the registration desk. There are the answer sheets given to you. You can fill in the answers and just deposit it in the drop box. They will be checked after the lunch session. I hope all of you have attempted it. It's open for faculty also to attempt. Just saying, if anybody wants to. Prize we will not get faculty, but it's fair. And the answers can't be anonymous. Please write so that we can give you. Just to tell everyone, in case of tiebreakers, we have really nice tiebreaker questions.
So good morning, and I am really sorry for the technical snag. In fact, what happened, I forgot to bring any pen drive. That's why I had to attach the laptop. Now talking on this topic is like Ashwini Vaishnav, there is a railway minister is presenting the budget, and Nirmala Sitharaman is sitting in the chair. Because this PPT was basically prepared by Dr. Jagdish Goyal. I had made some modifications, but we enjoyed the session in the Pediatric 2026. And that's why I suggested Induki, please keep this session. It was well appreciated in Kolkata. Now the capacity to learn is a gift, and I have time of 40 minutes. We have 5 cases, so I will not spend more than 8 minutes per case. So the capacity to learn is a gift, the ability to learn is a skill, and willingness to learn is a choice. And the last line is applicable to me. And the topic is this: you know all the experts, and I am the moderator as well as learner from the experts. Now going straight into the case, the first case, the history is 6 weeks old girl. Do you have a pointer? Okay, normal pointer, okay. So, okay. So the girl is 6 weeks old. Okay. So the girl is 6 weeks old. She is having persistent tachypnea, and that was noticed at 5 days of age. Antenatal scans were normal, born at 37 weeks. At the day of 5, the parents noticed there was a tachypnea. And the tachypnea worsened, affecting the feeds. The examination, heart rate is 160 per minute. There was tachycardia, there was tachypnea, saturation normal, good air entry bilaterally with moderate subcostal recession. There was no wheeze or no crackles. Dr. Nanavati, your thoughts and how to proceed in this case?
We can go back to the previous slide. Hello? Now, if we see here we have a baby who is an early term. Though we don't have other details like birth weight of a child.
Birth weight was 3.
3, okay. So this is early term 3 kg, born by LSCS. And on day 5, there is a baby has tachypnea. Now, sometimes the term infants, during this transition period, they can have the respiratory rate between 60 to 100, and then generally will settle to 50 to 60. But these are the babies, they don't appear distressed, and they are able to adjust their rate, and they are able to breastfeed successfully. Now, if we look at this particular child, that there is an evidence of subcostal retraction, and that tells us that there is a respiratory distress. It is not just plain simple tachypnea, but there is a respiratory distress, and you require to go ahead with the investigations for this baby further. So that is what we understand from this case.
So I give you 4 clues. Is it a congenital lung problem? Is the child suffering from some infection with the given history and findings? Is the tachypnea due to metabolic problem? or any cardiac lesion be responsible? At this juncture, what do you think most
so now
suitable for
as,
this child?
this thing, as we said, the tachypneic babies who are tachypneic because of hyperventilation to increase the oxygen or to eliminate CO2 or for as a compensation of metabolic acidosis, they will not be able to breastfeed successfully as the earlier babies.
Right.
So now since the history dates back to day 5, and the baby has respiratory distress, it points more towards a pulmonary cause and not the, so the pulmonary cause will be first because there are significant subcostal retractions. When we talk about, infection, now we don't have the history what happened in between, but babies with congenital anomalies, if you have an infection and the X-ray shows you involvement of the same region again, then there could be the possibility of infection, which we are not seeing here. And cardiac possibility you have to keep in mind.
So this is the X-ray. This is the X-ray.
Yeah, so this X-ray, what it shows us, that it shows us the hypertranslucency of the right, there is also X which is anterior to the heart because you can clearly see the margins, and what you have to note is hyperlucency, there is a shift of mediastinum and you are able to see the bronchovascular markings, and the collapsed lung is not seen because here what you want to differentiate is from pneumothorax, and putting a tube, if some wrongly diagnosed pneumothorax, is going to be a disaster. So since the, the collapsed lung is not seen, the vascular markings are seen, this goes more in favor of, the anomaly like congenital overinflation or what earlier used to call as congenital lobar emphysema.
Okay, so you are thinking a congenital lung problem where one lobe has expanded and almost herniated into the left side.
Yeah.
The lung markings are visible. There is no collapsed lung that is visible. So let us see. This is the CT. Shilpa, what do you see in the CT?
So in CT also basically this the right side of the lung is herniating to the left side. There is mediastinal shift, and you can see some posteriorly the lung is you can see in one of the cuts on the right side, extreme right side. So looks like overinflation, emphysematous lung, and all the lung window you can see this, and mediastinal window is normal, like it
so
is also
showing. In the mediastinal window there is nothing to say much.
Yes.
But in the lung window there is a compressed lower lobe.
Yes, yes.
It is more in the upper lobe.
Upper lobe.
And
yes.
it has herniated into the left hand side.
Yes.
And in some places you can identify the bronchovascular markings.
Yes.
Some places you can identify, right? Dr. Bafna, you want to add anything?
At CT scan, I think most of the points are well taken. I think if you go back to the history, this was definitely a parenchymal problem, subcostal retraction, persistent hypoxemia, and the child having persistent hypoxemia for 6 weeks with room air saturation of 97. That means it is not a diffuse problem, more likely to be a localized parenchymal problem from the history, and localized parenchymal problem starting at day 5, congenital most likely,
Lung
cardiac
problem is most
unlikely.
Yeah. So how to differentiate between a congenital lung overinflation and a CPAM? In congenital lung overinflation, you can see the bronchovascular markings. If you go to the X-ray, if you see the X-ray, bronchovascular markings are there, but in CPAM, in the cyst, bronchovascular markings will not be visible. Now, gross mediastinal shift, but from different diseases. This is our X-ray. This is another X-ray, this is another case, this is another case. Now my question to Dr. Jagdish Goel, infant with tachypnea and this type of X-ray, what other diseases you can think?
Okay, so as we have discussed about this case, this is congenital lobar hyperinflation. One of the differential diagnoses is shown in second X-ray, which is there are thin wall cystic lesion is there. Second, this one. There are thin wall cystic lesion, so which may be there in congenital means pulmonary airway malformation, CPAM, or sometime in necrotizing pneumonia with the staph infection.
This is the CT of the same child.
Okay. Then it is more likely of thin wall cystic lesion with area of consolidation. So more likely this suggestive of CPAM if we'll go by history. And this X-ray you can see that there is definitive collapsed margin, as rightly told by ma'am that if we have collapsed lung margin and there is no vascular marking, there is hyperlucency and you can not see the lung vascular marking in this. So this suggests that child is having pneumothorax.
So this is a child with pneumothorax and the child was suffering from RDS.
Yeah.
And the lung was stiff. That's why the collapse is incomplete.
Yeah.
So these are the different other condition where you can get this is same type of radiological picture. So what is the final diagnosis? Dr. Jagdish.
So final diagnosis in the given case, since there is hyperinflation of the lobe and there was no attenuation of vascular marking, but there was no absence of vascular marking.
Right.
And mediastinum means lung is herniated to this hyperinflated lobe is inflated to right side. So all these findings suggest that we are dealing with congenital lobar hyper.
Okay. So the learning point is that you can expect some tachypnea up to 7 days in a newborn, but beyond 7 days, if the tachypnea persists, then there is something else you should think. CLO typically presents in the neonatal period, but can present as late as 5 years. So third, chest CT confirms the diagnosis. CLE earlier we used to say emphysema, but is nothing to do with emphysematous change. It is basically a problem of the cartilage. It's a ball valve action. The lobe gets overinflated. Antenatal scan may say a solid tumor, because before the air enters the lobe, it may look like a solid tumor. So antenatal scan, if says it is a solid tumor, don't rule out CLO after the presentation. So the road to diagnosis is onset on 5th day. Most likely it's a congenital lung problem, chest X-ray overinflation of a lobe, CT no cyst bronchovascular markings are seen very clearly. Now a question for the audience, which is the most common site for CLO? It is the left upper lobe, then right middle lobe, then right upper lobe. Okay. Yes, sir.
No, I just wanted to make a practical point that in the baby it's tachypnic, and if you even if the baby has say CLE, and if you happen to take the X-ray on day 1, it will show you the opacity and not the translucency, because fetal lung fluid is not yet absorbed. So that is one important thing. If you take X-ray immediately, after the fluid gets absorbed, you will see the translucency. And second thing, whenever we are interpreting the X-rays in the babies, we have to see for the integrity of the diaphragm, because otherwise sometimes the diseases like CCAM might be wrongly diagnosed as diaphragmatic hernia. So one has to see, as we have said, collapse of the lung, shift of mediastinum, and the integrity of the diaphragm. So these are important practical points.
Dr. Bafna. Yes.
So the diagnosis was lobar overinflation, and in these patients, it is very important that we rule out secondary causes of lobar overinflation.
Yes.
Rather than just saying that this is congenital, and the CT, which should be done contrast CT and not a plain CT. If you don't do contrast CT, you may miss a mediastinal, say, bronchogenic cyst or duplication cyst, which is compressing the bronchus and causing overinflation. Yes, or you may have a bronchial stenosis, which is actually. So either do a good contrast enhanced CT with airway evaluation in that CT, or do a bronchoscopy to rule out that you are not missing an interluminal obstruction or extraluminal compression.
That bronchoscopy was done, which was normal. So the second case, the child was 6 months old male, normal delivery, cough, fever, breathing difficulty. Earlier also there was some cough, but the cough, fever and breathing difficulty, failure to thrive for 3 months. History of admission twice outside our hospital, treated as pneumonia, received IV antibiotic on an average 10 days each time. Mother says the baby have discomfort after feeding, vomit sometimes, and cough escalates after the feeding, persistent tachypnea in between, and no hemoptysis, no CNS sign. Now the heart rate is 138, respiratory rate is high, SpO2 is normal, CFT normal, weight is low, very low, head circumference is almost normal and slightly on the lower side. Chest crepitation, bilateral crepitation is there, S1, S2, no murmur, par abdomen, soft liver, 1 centimeter, CNS alert and active. Your thoughts on how to proceed, Dr. Shilpa?
Sir, can we go back to previous slide? So basically, this child who is 6 months old, the child is suffering since last 3 months with fever, cough and breathlessness. And the most important point here is that child is failing to thrive. Admitted twice with pneumonia, and this child now is having persistent symptoms. So this tells me that this child actually has some chronic illness, some chronic pathology, so that is definitely there on X-ray, and there is an infective etiology also many times, which is having pneumonia. Now the examination finding, presently this child is definitely sick, has tachycardia, has tachypnea and retractions also, crepitations also, and the weight is telling that there is significant failure to thrive. So
yes.
Presently this child is again having an infective episode, again has pneumonia sort of a thing, because there are crepitations. So this is a third episode of pneumonia. So I would keep a few things in mind, and I want to investigate this child.
Right.
Like this child, again a typical history was there that the symptoms always started after feeding, and there is a history of vomiting also. But there is no history of choking in this child.
No history.
So this history, I would take it in, like I want to give importance to that. If a child is having symptoms like cough after feeding, so I will definitely keep reflux as one of the component in this child. Many times reflux is associated with other pathologies also. So you need to think other pathologies also in this child.
We will come to that, but these are the two X-rays, and the mother says at the time of swallowing there was no problem, no cough, no episode of choking, hemoglobin is normal. And what you see in this X-ray?
So the X-ray 1 month back is showing infiltrates on the right side, and just few infiltrates are also seen in left upper lobe also, but significant infiltrates seen in right upper lobe and the middle lobe also. And the second X-ray there are significant infiltrates bilaterally all over all the lung fields.
So, Dr. Bafna, you are allowed to perform 4 tests apart from chest X-ray. What are the tests you will choose?
So I think this child has an aerodigestive problem. This child had an airway issues, probably parenchymal also. He's aspirating, I feel, and also is involving feeding related cough, which is not on choking. So probably aspiration from down or maybe in the chest. So my investigation for screening, maybe barium swallow would be my first investigation, which will tell me some degree of aspiration. And then of course, if I really want to know where the aspiration is occurring, I would do a triple scopy. So I think it will depend on which center and what you are doing. But I would do a scopy to know aspiration from above, aspiration in the chest, fistula, and of course simultaneously reflux.
But there is no history of choking or swallowing difficulty.
But reflux can be there, so the gastroscopy can
so
help me.
Will you consider?
But otherwise, barium swallow is my first investigation.
Okay.
Second investigation would be CT or scopy, which institution I am working and what is available. Barium, usually we are now doing VFSS and barium together in all the patients. So it is telling me the swallowing, and so when I say barium swallow, I VFSS with.
So you will not do any 24-hour pH manometry or GE scintigraphy?
They are not available in my center.
Right. Okay.
So I think they are theoretical.
So, Dr. Jagdish.
Just to add on this, sometimes we are having airway malacia, which might not be evident, with stride or presenting with stridor. So as Dr. Bafna rightly told, that we'll do bronchoscopy because
definitely bronchoscopy should be done. Yes.
So, and multi-channel impedance means nowadays is current investigation of choice.
Yes.
We recently had in our institute around 3-4 months back. Means with multi-channel impedance, we can see acid reflux as well as non-acid reflux.
Non-acid reflux.
So if facility is there, then definitely I can go with multi-channel impedance.
So what you see in the CT?
Okay. So if we look at the CT, there is opacity in bilateral lower.
Not a very good CT, but
So I'm straight away going into the lung window. So in lung window, if I see that there are bilateral lower zone opacities are there. So these again suggest that we are dealing with some
aerodigestive problem or aspiration. So bronchoscopy done, nothing detected, and will you be interested in doing this test, and how and why this test is performed? Can you explain the result of this test?
Okay. So this is a GR scan. Okay, might not be available at everywhere, but in our institute we are having this GR scan because we are having dedicated nuclear medicine department. So we used to send the patient because VFSS is done by radiology department. So our radiology team is having very high patient load. So sometimes means they deny for this VFSS study, unfortunately. So we tend to send the patient to our nuclear medicine department. They are having good liaison with us. So this milk scan means GR scan is done in this patient. So scintigraphy shows the evidence of reflux. So in this patient we found that.
And the reflux extent also you can see it is up to the upper part of the digestive tract. And VFSS and FEES, there is an integral difference. VFSS is through X-ray and FEES is by endoscopy.
And one more advantage FEES we can do on bedside also, bedside evaluation. For VFS you need to send the patient to radiology department, but there are advantages. In FEES we only see the this pharyngeal phase, okay, and in VFS you can see the esophageal
swallowing phase. All the 4 phases of swallowing.
All the 4 phases of swallowing you can assess with VFS. Yeah.
That's, yes. So suspected aspiration syndrome, I am not going into the details, but you go for aspiration from above. This is the list of the tests that will help you. This is the list of tests which will help you if the aspiration is from below. And the pointer comes from the history in many of the times. If there is history of choking and difficulty in swallowing, it is probably a aspiration syndrome which is causing from, which the problem is from above.
Subhashish, aspiration can be in the chest also.
Yes.
Fistula.
Yes,
so you can have from above, below, and
from above, below, and also from the fistula also, definitely.
So milk may not pick up that. And barium swallow can
and we have done bronchoscopy. We have done bronchoscopy, and which was normal. So to you, differentiating points from between aspiration from above and aspiration from below. Dr. Bafna.
So obviously when you have an aspiration from above, there will be, the problem is occurring during the swallowing. So there is a swallowing dysfunction.
Right.
Typically a neurological child, hypotonic child, CP child, where their aspiration is occurring from above and the child will choke while feeding. So the complaints are immediately or during the process of feeding, whereas when there is an aspiration reflux occurring, usually the cough will occur after feeding.
After the feeding.
So not during the feeding. So the child will have feeding difficulty, choking and coughing, whereas in reflux it is mainly coughing after feeding or cough associated with feeding. So that's how I think.
Right. So, but there can be a silent aspiration. Yes. In 40 to 90% of the children, there can be silent aspiration if the child is suffering from, even if the child is suffering from laryngeal cleft. And for children who present with chronic respiratory symptom, lack of history of recurrent pneumonia does not rule out aspiration. That is very important. So the road to diagnosis is problem started in early infancy. Mother gives the history of cough, vomiting immediately after feeding. No problem while swallowing, no choking, chest X-ray and CT aspiration normal, bronchoscopy normal, no fistula and laryngeal cleft. GE scintigraphy was very suggestive. Now this is not for the panel discussion. This is another child. The history is 7 months old boy. This is just to tell you the history and the findings. 7 months old boy, wheezing since 2 months of age, worse after the recent infection, probably RSV. History of frequent vomiting, cough, wheezing during after fits, and budesonide short-acting beta agonist, there was no benefit. Food thickening, esomeprazole for 1 month, no benefit. FOB, that is fiber optic bronchoscopy anatomy, was normal. Lipid-laden macrophages were normal. VFSS aspiration plus. Repeat VFSS after 1 month, same. And the child was ultimately diagnosed by an ENT surgeon with a rigid bronchoscopy, grade 2 laryngeal clefts. And so laryngeal cleft is better picked up, though can be done by FOB, but better picked up with rigid bronchoscope. And the question to audience is, a gold standard investigation to confirm oropharyngeal aspiration in infant is chest X-ray, HRCT, VFSS, upper GI endoscopy. Any clue? Dr. Jagdish, what is the correct answer?
So, if I choose from these options, so I think best answer will be modified barium.
Yes, thank you so much. So the third case, 11-month-old female, was fine till 4 months, Severe viral pneumonia at 4 months required PICU care. In last 7 months required 2 more admission for cough and respiratory distress. Inhaled corticosteroid, ipratropium plus short-acting beta agonist plus antibiotics intermittently, prednisolone for 4 to 7 days by the local pediatrician. Persistent tachypnea, which is the theme for this discussion, wheezing and cough. Parents are in desperation, came to you, your thoughts, Shilpa.
So this is a typical history that at 4 months child has had a severe pneumonia. So previous slides.
Oh.
So child has had a documented respiratory severe pneumonia at 4 months, and after that the child is suffering continuously, has required hospitalization, has significant distress, and is wheezing. So this is a very typical under 5 wheezer, infant actually who is wheezing after a illness. So it could be a significant post-viral insult which has happened probably, and the symptoms are ongoing since that time.
So the weight is 6.5, high respiratory rate, there is hypoxia, there is hyperinflated chest, diffuse rhonchi, few crackles, prolonged expiration, sweat chloride negative, and your thoughts on what tastes are most appropriate, Dr. Bafna.
So again, we had an absolutely normal child and who had persistent or recurrent wheezing with background tachypnea. So airway, probably small airway involvement because there is a tachypnea and saturation is also low. So there is hypoxemia, which is, and you have rhonchi and crackles both. So I think this is something which has happened after the pneumonia.
Infection.
So whether this is a post-infective insult which has happened, that is one possibility. Whether there is a small airway involvement which is, now again in this child, we have to think of aspiration again, because this child is having recurrent wheezing, has persistent tachypnea, so aspiration comes as a second possibility. Congenital comes slightly late because it is not, it's almost normal child.
Do you think steroid will help in aspiration, or how frequently you see?
Steroid has helped in this child, but that was an acute exacerbation which happened. So acute exacerbation.
How many cases of aspiration you have seen hypoxia frequently?
So what happens is in aspiration, as you said, there is micro aspiration. So you have persistent tachypnea going on, and then there is an exacerbation. That exacerbation will be bronchospasm, inflammation. So steroids may help. So so you would think of post-infectious bronchiolitis obliterans in this child.
So aspiration should be kept in mind.
Aspiration should be kept in mind.
Not typically fitting in.
So recurrent bronchiolitis here, but this is more of a post-infectious bronchiolitis.
Right. Now these are the X-rays you can see. Does these X-rays strongly indicate any specific pathology or any specific pattern, Dr. Jagdish? This is the first admission where you can see almost an upper lobe consolidation. Left also is involved to some extent. On the second admission, interstitial shadows are more. The third admission, nothing much except the border of the hearts, there are interstitial shadows. So Dr. Jagdish.
So looking at the X-ray, we are not able to pinpoint any diagnosis in this case, because there were diffuse bilateral reticulonodular pattern which may happen sometime in recurrent viral lower respiratory tract infection also. Okay. So if child is hypoxemic.
So no specific pattern can be identified in these three X-rays. Yes. Meanwhile, during the first admission, this was the report, and adenovirus was detected. And again, these are the tests available in your institute. Bronchoscopy, barium swallow, HRCT, 24 hours pH monitoring.
Dr. Subhash, I want to make a comment here. Yeah. So when we have child with multiple respiratory things, shouldn't we also think of immunodeficiency? We have not done a biofire once when showed RSV. The other 2 times we have not done. There's hypoxia. We have had children with severe combined immunodeficiency with hypoxia.
Yes.
PCP was the bug.
But
so I think this is one thing, even if you have only respiratory and not, like as the teaching goes, you need to have multi-system.
But the X-ray is not...
Yeah, so see, you can have lots of phenotypes, and we have had 2 children like this in the past, so that's why I'm making a comment.
Yes, it is.
So even if it is not multi-system, we currently also have 2 children like this only coming with respiratory.
It is a yes, it is a possibility, but it is a remote possibility.
Yeah,
Definitely.
so that one differential, I think we need to change our thought process now that we always say multi-system, but we had one child with PCP, hypoxia, and then turned out to be SCID. And SCID is being missed. So that's why I'm bringing out this point.
So what they are saying is, I think other possibilities like CF, PID, they are there, but they are down.
Sweat chloride was done and it was negative.
Actually,
Chloride was already done. So therefore, I thought
actually speaking, whenever we are dealing with recurrent pneumonia, we should look at 4 aspects, whether we are dealing with some congenital problem, lung or airway, then whether we are dealing with aspiration, whether we are dealing with mucociliary clearance defect, or 4th is immunodeficiency. So in 4 domain we look at and we need to evaluate the child.
So Shilpa, what is the next test? Or what are the next tests that are valuable in this case?
So in this child actually the most possible thing is that probably there is a chronic lung insult, especially after the first episode. Sweat chloride is already negative. So I want to do first test as HRCT.
Okay, this is the HRCT, that is the first admission.
Yes.
Then this is the second admission, and
Yes.
this is the last time when the child came to me. So this is the recent CT.
Yes.
Any diagnostic features you find?
Sir, in the last CT actually is classically showing mosaic pattern. You can see that some areas are very nicely inflated. And the other areas are showing significant interstitial involvement. And there is that mosaic attenuation, which is very classically seen in the recent CT, whereas it was not that obvious in the first CT.
But the thing is that here we can see some areas with ground glass opacity, which is not very common in mosaic attenuation.
Yes.
Mosaic attenuation is basically hyperinflated part as well as interspersed with a normal lung, and this pattern is known as a head cheese distribution, where you see some part is normal, some part ground glass, and some part is your hyperinflated.
Yes.
And this picture goes more commonly with hypersensitivity pneumonia. Sir, Professor Kabra, am I right? So this is the CT. Classically, you see in a mosaic pattern where you can find a patchwork of light and dark lung region, often called the small airway disease. And because of the air trapping in PIBO, the obliterative small airways disease, it is a problem of the small airways. There can be hypoxia, which is causing the constriction of the air trapping caused by abnormally low attenuation and exacerbated by reflex vasoconstriction. Low attenuation is maintained on expiratory CT. As the same person with 2 CTs, one inspiratory, one expiratory, you can appreciate the same cut. Expiratory CT shows the air trapping in a much better way. So most likely diagnosis for the audience is a very simple thing. It is the PIBO. So further investigation, bronchoscopy normal, BAL for cytology normal, GER scan negative, HIV normal. We have done the immunodeficiency studies, echo normal. Can we do some scoring for diagnosis? And Dr. Jagdish regarding the scoring.
Yeah. So I think maximum work was done by Tejer from Argentina, South America, and last year he conducted one workshop. I think Dr. Tanvi and I was there in this workshop. So he invented this score and it was published in Pediatric Pulmonology.
Right.
So if child is having typical course of bronchiolitis and if adenovirus positivity and mosaic perfusion in the CT, so they are given 4, 3 and 4 score, and if score is more than 7, then it is having good sensitivity, but still specificity is low. So I think we can do scoring and we can then decide about.
Yes, so there is a scope for the scoring, though
Sir,
it is. Yes.
So may I ask, what made one repeat a CT for the 3rd time? I mean, normally if first or second CT you don't find what you are looking for.
First and second were done by the institutions where the child was admitted. 3rd CT was done by a pediatrician, and after getting the CT, the child came to me.
No, I understand. I am asking that as a clinician, if I have done a CT and it has not shown anything significant.
These 3 CTs were done in a span of less than 1 year.
Sir, my point is I am going backwards. With that history, if I do a CT and if that CT doesn't show me some demonstrable issue,
It is
what
no
would
point.
make me do a second
Right,
and then a
right.
third CT?
And how it will change our treatment or
I
management?
think point is.
The only thing to
right.
answer you, Rajesh, of course, this is not justified at all. Unless the child is deteriorating, then I would do it. And then maybe on a follow-up later on to see where this PBO is going. That's the second time. But
You can
maybe
do
doing
once in
3
a year, I
CTs,
think, not
doing like
more
this is not
frequently than that.
justified.
Sir,
So I am saying the other way around. See, now that history was very typical of a small airway obstructive disease post-infection. So if I am desperately looking for something and I have not found it, maybe that is
So,
one reason I would
if
repeat.
the first CT did not do an expiratory scan, then you're not seeing air trapping and mosaic attenuation. Maybe I would have repeated one to look for that, but otherwise I don't think it's justified.
So the road to diagnosis is history. The problem started after a viral infection. That's a very typical history. Persistent tachypnea, not responding to ICS, SABA or short course of oral steroids, requiring multiple admission, and HRCT there was a mosaic attenuation. And these scenarios haunted us in Calcutta into late 2022 and 2023. Lot of children, infants died, and there were a lot of publications and paper insertions so far as the adenovirus epidemic in Calcutta in 2022 and 23. Now this is the 5-month-old infant born 32 weeks, uneventful perinatal, antenatal scans reported as normal, persistent tachypnea for 2 months, no fever, no recurrent infection, feeding difficulty with few choking, noisy breathing. Now the respiratory rate is slightly high, the saturation is more or less maintained, suprasternal retraction more, subcostal very minimal, audible biphasic stridor, chest equal ear entry, no adventitious sound, CVS normal heart. Whether the problem is in the lung parenchyma, airway or heart, differential diagnosis, and up to that Dr. Jagdish.
Okay. So if we'll go back to the history of this child, okay, child is having persistent tachypnea for 2 months, and there is history of noisy breathing is also, and worse with feeding and crying. So I think we are probably dealing with the airway problem. So there might be some airway problem which we are dealing with. Okay. So most common airway problem we encounter is airway malacia. So we might be having.
What is the most important clue in this slide?
Okay. So
Yes, it is a biphasic stridor.
yeah, biphasic stridor. Yeah.
Right. So, Dr. Bafna, what test you will advise?
Sir, coming to suprasternal, substernal retractions and stridor. So it is a airway problem and central airway problem. Biphasic stridor can be present if the child has severe dynamic obstruction also. So severe laryngomalacia, you will get biphasic stridor,
yes.
but this child is 2 months, was asymptomatic and presented quite late, so laryngomalacia looks unlikely. Any child who has noisy breathing stridor, first diagnosis is laryngomalacia. This child has presented much later, 2 months he will not, if he was not symptomatic, so unlikely. So other possibility of biphasic stridor is a fixed airway obstruction. Now fixed airway obstruction is either intraluminal or compression. If I am thinking of intraluminal obstruction, this child has normal voice, so laryngeal wave is unlikely. Subglotic stenosis, again there is no history typical, and severe subglotic would have presented at birth. So whether there is some compression from outside I have to think of, and would have to investigate accordingly. So there are a lot of causes.
So is there any findings in the X-ray, Dr. Bafna?
I'm not sure because there is some mediastinal widening. But I can't see the aorta. Means I'm not able to make out whether they, because what I'm looking at is some compression. So whether there is any right-sided aorta or this thing, but I'm not able to find.
I agree that means if you look at the mediastinum, then right side of mediastinum, I think there is some widening is there. It might be, though X-ray is not confirmatory, but there might be some right aortic arch.
So echo was done, structurally normal heart, right-sided aortic arch suspected, inadequate visualization of the full arch anatomy. Now Shilpa, the tests that are available in your institute and how you are allowed to perform 3 tests.
Yes.
Which one you will pick?
So the first test I would do is barium swallow because it is available everywhere, and that I'm not very expensive also and can be done very easily. So first test I would do as barium swallow, and then depending upon that I think I would choose CT angio chest or
not CTPA.
not CTPA.
Okay.
And bronchoscopy.
And what is the difference between CTPA and CT angio?
So basically CT angio is done, it is basically the timing of the contrast which has been adjusted. So CT angio is basically for aorta or systemic circulation in general, and CTPA is for pulmonary arteries.
So I don't have the full, yes.
In this child with a stridor airway problem, the first investigation is bronchoscopy.
Definitely.
This, I think this message has to go.
Yes, yes.
Because here we may have an aortic, right side aortic arch, but that's not a common situation. You need to look at the larynx, supraglottic.
Definitely.
aortic.
You must
So I would
visualize the
bronchoscopy
airway
and
first.
then
So
decide what my further investigation.
Yeah, so barium swallow, because he had even dysphagia, he was vomiting also, and barium swallow can be done very easily.
That is the most inexpensive test.
Inexpensive,
You can
not
do
very
it.
invasive also, and can be easily done.
Can be done.
And after that, actually, depending upon what is your differential diagnosis, you can choose to do bronchoscopy first, then CT angio, or
So basically
CT
it is
angio
a
first and then
bronchoscopy, barium and
three.
CT angio.
All three
So you have a pulsatile indentation in the left main bronchus. I don't have the full video. And this is the barium. So can you make the diagnosis?
Yes, so because there is a significant indentation on barium swallow, you definitely know that there is an extrinsic compression there. But sometimes, like in bronchoscopy also, you can see that there is a asymmetrical tracheomalacia is there. So probably, and if there are pulsations, you know that it's a vascular thing which is compressing. Many times even subglottic hemangiomas can present with biphasic stridor, and they may have even feeding difficulties also. So bronchoscopy can rule out these things also.
So Dr. Jagdish, when bronchoscopy is available, why do we do the barium swallow?
Dr. Silpara pointed out that bronchoscopy might not be available everywhere. So this barium swallow.
This is very inexpensive and can be done very easily.
And non-invasive test also. So maybe, but as means I will go for bronchoscopy.
Bronchoscopy first, definitely. So this is the CT angio where you can see the right-sided aortic arch, and normally when double aortic arch, the right becomes the dominant one. This is the complete ring. There is an indentation on the airways also, and contrast in the right upper limb. As soon as it is being given, there is a venous phase, there is an early arterial phase and the late arterial phase, and the brightest structure after giving the contrast is the SVC. Then comes the pulmonary circulation, and the contrast flows in that way. So CTPA is basically for embolism, or to see the pulmonary circulation. And doing the CT angio, you can see the aorta also, the ascending, descending, and the arch also. I am not going into the details of this thing. So basically there is a dominant right aortic arch and the small left aortic arch. This is more than 50% of cases of double aortic arch. This thing happens, and there is a compression of esophagus and the trachea also. Now, causes of the biphasic stridor is a vascular ring, vocal cord paralysis, subglottic stenosis, severe laryngomalacia, and foreign body if the onset is abrupt. Am I right, Dr. Bafna? Okay. So I will skip all other the next case because the time is up. So the road to diagnosis here is the biphasic stridor, feeding difficulty with few choking episodes, bronchoscopy, and the barium swallow was diagnostic, and CT angiothorax also confirmed the case. And skipping this thing, the last slide. Yes. So the common causes of persistent tachypnea of infancy in the lung is CLO, CPAM, agenesis, hypoplasia, neuroendocrine syndrome. Polycythemia, if it is persistent, more than 65, can produce higher respiratory rate. Aspiration, GERD, tracheoesophageal fistula, laryngeal cleft, post-infectious PIBO. Allergy and Heener syndrome, cardiac ring sling, Alcapa, and total anomalous pulmonary venous drainage. And recently I saw a very surprising case from Darbhanga. The child came to Calcutta for treatment, partially treated meningitis, and the child presented only with tachypnea. The child was failure to thrive and tachypnea. And ultimately it was found the child was suffering from partially treated meningitis. So practicing pediatricians are submerged in routine cases, and sometimes we should think out of the box to reach the diagnosis. Thank you so much for your time and attention. Give a big hand for the panelists. They have done an excellent job. Thank you so much.
It was truly a wealth of knowledge. I request Dr. Uday Pai sir to please felicitate Dr. Subhashish sir and our esteemed panelists, Dr. Jagdish sir, Dr. Sanjay sir, Dr. Shilpa ma'am, Dr. Ruchi ma'am. And please keep the applause going. We had a fantastic opening session and we hope to keep the momentum going with this. Don't give it to me. Orange is mail, right? Yes. Take and go there. Dr. Shishir sir का load हो गया ना? Can you please keep them ready? Everyone, I hope we opened the morning. I hope this makes the radiology quiz a little easier. I think the people who solved it in the morning will regret it a bit. So for the next session now, we are working in a series of alliterations. So now we are introducing the big C's, the childhood wheezing, consensus, controversies, and clinical practice. And for this, the moderator is none other than Dr. Shishir Modak sir, a senior consultant from Dinanath Mangeshkar Hospital, Pune, author on the chapter of the management of asthma in the textbook of Pediatric Pulmonology. He's been national convener of the asthma training module 2021-2022 and the under 5 wheezing model 2020. I welcome you, sir. Our panelists to share their knowledge on this, Dr. Ajit Gajendra Gadkar sir, consultant pediatrician, Hinduja Hospital, who has special interests in this field. Dr. Jayan Joshi sir, our chairperson of IAP NRC. I welcome you, sir, to share your experience. And Dr. Rawat sir, our past president of IAP NRC and has been executive editor of the IAP NRC textbook of Pediatric Pulmonology. And Dr. Minaj Sheikh sir, consultant pediatric intensivist and Leelavati Hospital, who has a special area of interest in pediatric acute care and infectious diseases. Welcome, sir.
Full screen. फुल स्क्रीन तो कर्सर जात नाही देत पण Very good morning to all of you. I welcome you all for this interesting session of childhood wheezing, consensus, controversies and clinical practice. At the outset, I would like to thank the organizing team, particularly Dr. Indu, for inviting me here to moderate this session. When I talked to Dr. Indu about this topic, she said, though wheezing is mentioned in the topic, you cover all the age groups and discuss management of asthma. Don't go for diagnostics. Go and focus on management. But even if you consider management, asthma is such a vast topic that it may go for hours together if you discuss the entire management. So what I have done is I have chosen only those points where there is some controversy or there is some discrepancy between the guidelines and management in clinical practice. I have got excellent faculty, they are already introduced, so I won't spend time. Dr. Rawat from Indore, he was the former chairperson of IAP NRC. Dr. Jayant, who is the current chairperson of IAP NRC, he is with me in Pune. Dr. Ajit Gajendra from Mumbai, Hinduja Hospital. and Dr. Meena Sheikh, intensivist from Lilavati Hospital, and I am Dr. Shishir Modak. Now we straight away go to the cases. So here is a Soham, who is a 2-year-old boy, presented in OPD with history of wheezing, cough and breathlessness 2 days back, no cold or fever. On examination, afebrile, no distress, mild wheezing present on auscultation. As per history, Soham responded well to inhaled salbutamol given twice. One mild episode history was there 3 months back, responded then to oral bronchodilator given by a GP. No history of interval symptoms since that episode and no history of hospital admission. There were no allergic markers and no family history of asthma. How will you manage Soham now? Dr. Rawat?
Okay. Thank you very much to IP Mumbai and Dr. Indu for giving the opportunity. So obviously this is a child who he's having recurrent wheezing. Now, is there any past history of admission? His perinatal period, everything?
No,
there is
no history of admission.
So no history of admission in the past, and there is no perinatal abnormality. The child who is having recurrent wheezing. So I think GINA 2025 has given some very excellent guideline regarding how do you manage these children who come with recurrent wheezing with no other apparent cause, because the main dilemma is to differentiate whether they are having an asthma or they are just a viral visa which is going to get all right as they grow. So these 3 points which GINA has mentioned 2025, they are very handy for a pediatrician, where you can differentiate these children who are going to respond to your inhaled corticosteroids, your treatment of asthma, versus just manage them on SABA. So the first criteria is the child should have a recurrent wheeze. Recurrent means at least more than twice, or one wheeze with interval symptoms. Now this wheeze has to be confirmed by a doctor, because sometimes parents might tell you that child has wheezing, child ko awaaz aati hai, but that could not be a wheeze. So first thing very important you should remember is that it must be confirmed by a doctor, or very rarely a very intelligent parent, they bring a recording and tell you that the child is wheezing and you see it. Otherwise, first criteria, because asthma, wheeze is indispensable for asthma. Child has to wheeze. So wheezing confirmed by a doctor at least more than twice in a year, or one wheezing with interval symptoms of asthma, like he's having cough which is getting more worse in night or more worse in exercise. That probably point out towards a variable symptoms. Variability is a hallmark of asthma. So variable symptoms, wheezing, that is the first criteria. Then second thing is that there is no alternative cause, as Dr. Modak is telling. Otherwise, there is no past history of admission, there is no other perinatal insult, child apparently looks growing well. So there is no other apparent cause. So that is the second criteria. And the third criteria, very important, child should respond to your bronchodilator. Child should have some amount of variability of airflow, because for asthma there are classical, the symptoms should be variable and the airflow should be variable. So this variable response to bronchodilator, it indicates a variability. So the child, again, the response should be timely. Parent will tell you that we give nebulization, child gets all right. We don't know in how much time. So GINA this time has given a very important clue that it should be a timely response to bronchodilator. That means that if you are giving SABA, it should respond within 20 to 60 minutes. A prompt response. If you are giving more serious child, given steroids and SABA, it responding within 3 to 4 hours. Or giving a trial of ICS in about 2 to 3 months. So a very specific image, because you can progress to this child where you put this criteria and definitely you can decide whether.
So Dr. Rawat, how will you apply these criteria to this Soham?
So he had 2 episodes of wheezing, there is no doubt, because this came to you for the second time and you confirmed their wheezing. So wheezing is there is absolutely no doubt. 2 episodes of wheezing are there in a year. So first criteria is being met. Second criteria, there is no apparent cause. The history and the examination tells that there is no apparent cause. The third important reason, the child should respond timely. Now child responds, but we don't know in how much time. He might get all right on its own, or he is responding to bronchodilator, we don't know. So probably in this child, we need to put him on a thing known as a trial of SABA. Now there are specific reasons where we put SABA trial. A child who is having mild episodes, or a child was never hospitalized, he never required steroids, or the symptoms are less than twice a week in past 1 month. These all are cases, are mild cases where we put the child on SABA trial. We give the parents salbutamol MDI in a spacer, tell them how to use it, and then tell them specifically, whenever he gets wheezing, use this particular salbutamol, you give 2 puff, and see the time in which the child responds. If the child, after follow-up, say after 2 or 3 months, child come back to you and parent tell that he had 2 episodes of wheezing, he responded within say 20 minutes or 30 minutes, less than 60 minutes, it is a positive SABA trial which confirms that there is an appropriate response to SABA.
Right. So in previous GINA guidelines, timely response to treatment, particularly bronchodilator treatment, was not so much emphasized. But GINA 25 emphasizes that response should be in 20 to 60 minutes after giving bronchodilator. So in every case, whatever wheezing case comes to you, recurrent wheezing, it should be analyzed in this manner. Now, I like to tell the audience that earlier session was a difficult cases session for pulmonologists. This is a very simple session and it is mainly addressed to general pediatricians.
Can you apply the criteria recurrent to this in the second piece itself? Because by and large we talk about 4 episodes before we classify it as recurrent. So can you use the guidelines for
that has changed now 2025.
No sir, it's 2. It is 2. If you have
now
2 episodes, recurrent wheezing.
But anyway, I'll again request audience that all the questions we'll take after the session. Otherwise, we will not be able to finish on time. Lot of things to be covered. Yeah, so now here, Dr. Jayant, Sia, who is a 3-year-old girl, history of acute episodes of wheezing, cough and breathlessness. Wheezing started 2 days back. Now wheezing is less, but dry cough is present. On examination, Sia is afebrile, no distress, few rhonchi and expiratory wheezing is present. So wheezing is confirmed on auscultation. CBC X-ray test was done by practitioner, it is normal. History of recurrent wheezing since 1 year. Now she is 3 years. So mostly afebrile episodes 3 to 4 times in a year. In last 1 month, she has nocturnal cough more than 2 to 3 times in a week. Every time there was history of good response to salbutamol nebulization, and this acute episode was also treated with nebulized salbutamol, to which she responded well. Later history was obtained that child had eczemas in the past and father has history of allergic rhinitis. What would be the treatment approach for Sia now?
Yeah, so first of all, thank you.
Before coming to Jayan, this is audience question. There are 4 options. Sia should be treated with Montelukast, Sia should be given salbutamol only, Sia should be given short course of oral prednisolone, or Sia should be given a trial of ICS. Very simple question. So this is not, I said it's for general pediatrician. Okay, go ahead, Jayan.
Yeah, so can you just show the previous slide, please?
History.
Yeah. So, in comparison to the first case, this child has got frequent symptoms. This child has had an acute episode of wheezing before. The child has had recurrent wheezing since 1 year of age. So, you have had several episodes in the past also. Investigations probably were not warranted, but were done by the practitioner, which were normal. And every time the child is responding well to salbutamol nebulization. So, it's a good response to bronchodilator therapy. So coming to the same comparison as we now do for all under 5 by the GINA 25 guidelines, she had acute episode of wheezing for which she was taken to the emergency room. So it is a severe episode. She has recurrent wheezing more than twice in a week, complaints in the last 1 month. And though now the GINA 25 guidelines do not emphasize too much on history of eczema or family history of atopy, in earlier days we used to give a lot of emphasis on these points. So this again suggests an atopic tendency. On history, the child, of course, on examination, the history is so typical that there are no alternative conditions that are likely. She has responded well to salbutamol. Again, as you mentioned, the exam type duration is not mentioned. So, as Dr. Rawat sir said, it should be now 20 to 60 minutes, and that is what the guidelines mention. Yeah. So, Sia definitely meets 2 of the 3 criteria, and due to the frequent symptoms, she should be put on a trial of daily ICS and short-acting beta-2 agonist as required.
Yeah. Now what happens in practice that the diagnosis of asthma is not made correctly below 5 years. Like GINA 25 said that only 2 wheezing episodes or more than twice in a week interval symptoms, that is sufficient. You need not wait for 4 episodes to happen. So we have to change our learning. then usually only salbutamol nebulization is given without using controllers. So that's why no anti-inflammatory drug goes in. And sometimes ICS trial is started by some pediatricians, but not done adequately. They may stop after 10-15 days only. So these are the mistakes or discrepancies which happen in clinical practice. Now Jayant, how exactly the trial should be done, ICS trial?
So I think if you look at the criteria in a child who fulfills this particular presentation, acute severe episode, no alternative diagnosis likely, and a good response to bronchodilator, this probably should merit a trial of inhaled corticosteroids. It should be ideally done for 3 months period. As we had mentioned earlier, you start the trial, only difference in this particular guideline is that you have to increase the beginning of the trial with high dose of budesonide. So we start with 200 microgram twice daily for 3 months, and thereafter we see how the child is responding. Now, if there is no response in 6 weeks, probably it is a thing which probably should be seen by an asthma specialist. So we are thinking of other possibilities. Whereas in the commoner ways, when we find a good response to a inhaled corticosteroid therapy, as in this case, probably the period would be around same. Then after that period, you reduce the dose. So after presumably by 6 weeks, you reduce the dose of ICS to low dose, that is 100 milligram twice daily. The difference now here is that earlier recommendations were that we stop the trial abruptly. The difference now is you have to continue tapering over a period of next 3 months. So again, after that, if the response is good, you step it down, bring it to once a day dose, preferably at night, and then review the child. And if the symptoms recur or they stop, then you have to think of restarting ICS.
Yeah, right. So this is the difference between what we were teaching previously. Previously, we were saying that after 3 months, you stop the trial abruptly, call the patient for follow-up, and that time you see whether the symptoms recur, and then you decide. But now Gina says that instead of abruptly stopping, you can reduce the dose. Once you are convinced that this is asthma and is responding very well to this ICS for first 2 months or so, then you can reduce the dose, and you don't stop abruptly, but then you treat as if you are treating an older child and reduce the dose gradually, maybe a period of next 3 months.
Just one small point to add. So here, when we are counseling parents for initiating the inhaled corticosteroid, don't give them assurances that it is only a short period. You can perhaps say that we are going to take a trial, we give it over a period of time, because otherwise they come with a preconceived notion that, okay, I'll do it after 2 months and we stop.
Yeah.
So that has to be changed now, and we tell them that we'll slowly reduce it.
Right, correct. So now coming to use of nebulizers. As all of you are aware, nowadays parents buy nebulizer at home and give home nebulization. What is the recommendation in GINA, and what is your take on this, Dr. Rawat sir?
So I think the recommendation for nebulizer is very clear in GINA. They always prefer MDI spacer is the very versatile device, there is no doubt about it. But nebulizer is not a non-touch. We have been taught that it is a non-touch, don't touch it. It's aisa nahi hai. Even in GINA they say that in some condition where child is not able to take MDI spacer, you have to give nebulizer, particularly in acute episodes where child is very sick, that you cannot treat by MDI spacer. So there are indications of MDI spacer in asthma, where in some children who are not accepting an MDI spacer, you can use nebulizer at home for maintenance therapy. In fact, I just seen Thai guidelines where in 2025 they have made guidelines where they have inserted the use of nebulizer for long-term therapy. Thai guidelines. So I think it's not something like it is untouchable, you should not use nebulizer. But of course, MDI spacer is a versatile device. But in some cases where you are not able to use this device, some parents, some children, they are very resistant. They don't want to use it. So in that case, definitely you can use them for long-term therapy. But of course, for acute case, you have to use.
Yeah. So GINA says that it is nebulizer is reserved for a minority of children.
Just one
as
small
when
addition.
possible, use MDI with spacer. Yeah.
To what Dr. Rawat sir said, home nebulization should be strictly discouraged.
No, sir.
No. Under
open a debate
patient's
here.
level.
Even in Thai guidelines, they have mentioned home nebulization, long-term therapy by nebulizer.
Yeah, the whole point about nebulization is it's very likely that it can be abused.
Yeah, exactly.
And
Misused,
secondly,
abused,
chances
not
of
used
patients-
properly, not cleaned properly, not sterilized properly. And you must have seen your patient may be telling that for common cold also they give nebulizer if it is at home.
And you
And
also
this is
probably,
a very common mistake that
as
happens. So
effective as a nebulizer.
better to avoid home nebulization. But if a long term, say it's a cystic fibrosis patient, then it's a different story.
And
Okay, but
Shishi
for
sir, it is
wheezers, it's not advisable. Yeah.
That it is not something like
It's not
non-touchable, but
I
you have to
agree
use
with
it
you.
wisely.
It's not untouchable. It has its own role, but should be used judiciously.
But at the
and
same
cautiously.
time, the message to the audience is that it should be discouraged. It should not be the preferred option.
Anyway, there was whole session in Pedicon on this nebulization therapy. Anyway, so now moving ahead, Ishan is a 7-year-old boy, history of frequent cough, nighttime awakening almost 3 times in a week, early morning breathlessness, many times a month since year. Most of the episodes are afebrile. He visits GP clinic and is nebulized with salbutamol several times a week. So parents have purchased nebulizer at home and he receives salbutamol nebulizer many times in a week. He misses the school once or twice in a week. How do you position this child? How do you decide level of control? Dr. Ajit.
Yeah, number one, you can see this is a classical case who comes to your clinic where he's never been told he's got asthma. He goes every time to a GP clinic, he's given a nebulizer with salbutamol, he feels better and he keeps coming back. So essentially, this is a child who has undiagnosed or an uncontrolled asthma, who has never been put on a controller, and hence he's never been able to, he's just keeping having these episodes again and again. So he would probably fall, looking at the characteristics, we look at how often are the symptoms, very often. Nighttime awakenings, often. It's, he needs relievers and rescue therapy often. So he's following in all the categories. He's probably falling into the uncontrolled asthma category where he has all of these symptoms.
Right. So the spirometry was also done. Nowadays recommendation is upfront at the time of diagnosis, spirometry should be done in children above 6 years. And Dr. Rawat won't allow to go ahead if spirometry is not done. Anyway, so
but it's very, very obvious that there is a reduced FEV1 with a 52% change post bronchodilator. So anything more than 12% is diagnostic of asthma.
Significant.
And it's significant. So there is no question.
Yeah. So now how will you initiate treatment in Ishan?
Now looking at the fact that he's having this symptom so frequently, I think if you go by the GINA guidelines, you'll probably strike straight to the third or fourth, step 3. So we'll have a medium dose LCS with LABA and as needed SABA, that is a standard care. But since he's 6 years and above, he's 7 years, you can even start on MART, which is a maintenance and reliever therapy. Essentially, that is a option that we have in starting.
Now, since here spirometry has confirmed bronchodilator reversibility and low FEV1, you can go straight away to step 4. And step 4 is medium dose ICS plus LABA or low dose ICS plus formoterol. But Ajit, which one you prefer? MART you prefer or previous older one?
See, I think when they come initially, you probably have to hit hard. You might even require initial dose of oral steroid for 3-4 days to control him. And nowadays I prefer MART because it's so much easier and they have to carry only one inhaler.
Yeah.
So
I think
MART
any day
probably used to be called SMART, which is a more right
Absolutely
name.
right. If
Single
it is MART,
inhaler,
it's so good about 12 years and MART is praised and it reduces exacerbations and so on and so forth. Why not even in 6 to 11 year group? Yeah. So what is MART? Dr. Minaz, can you elaborate on that?
Yeah, good morning. I mean, must say the flow of the presentation that we started from the 2 years, then 4 years, and then by 6 years. So it matches with the GINA guideline. Below 4 years, 6 to 12 years, and there onwards. So it is essentially 6 to 12 years, which is MART. Right. MART is maintenance and reliever therapy. What's that? This is a paradigm shift with regard to therapy in 2005 versus 2019. 2019 was essentially for only bronchodilator without our steroids. So here there is a change with regard to addition of steroids, wherein we have anti-inflammatory effects. So 2019 was essentially bronchodilator. MART is along with bronchodilators your anti-inflammatory therapy. So this is the paradigm change which is important. So why it is so? Because all these things is there. When we have only bronchodilator, no steroids, there are so many things. One of the important things is like the effects of you have only like the doses requirement is increases, the complications increases, wherein anti-inflammatory effect is not been there, and then you have already said increase in eosinophilic inflammations. So the MART is superior to your only bronchodilator therapy.
Absolutely, and it is mentioned that if you use more than 3 canisters of salbutamol per year, there is increased history of ER visits, and if there are more than 12 canisters, that means if you consume more than 1 per month, that is 12 per year, then there is increased risk of mortality also. So what is the advantage of this budesonide formoterol?
So I said the essential concept is anti-inflammatory therapy. So you have eosinophilic inflammation, it takes care of the inflammation parts. So less ER visits, more of more control and more effective treatment.
Yeah. And the most important point which Gina mentions again and again, that it reduces exacerbation significantly, more than 65% if you use budesonide formoterol as a reliever instead of salbutamol.
So now, what is important to note that salmeterol fluticasone is not part of the MART.
Yeah, absolutely. No. It has to be formoterol.
No, it's a formoterol. Yeah, it's a formoterol.
It's only formoterol which has
absolutely. Yeah. Because some pediatricians still use salmeterol fluticasone, but I don't know, and I wonder why salmeterol should ever be used nowadays. So it should be budesonide formoterol. So it should be formoterol combination. Formoterol is LABA as well as rapidly acting. So that formoterol containing combination only can be used as reliever. Now Minaz, so what is this very low dose MART and low dose MART? Because in step 4 you have seen step 3 that is very low dose MART, and in step 4 that is low dose MART. So what is the difference between the two?
Yeah, with respect to this particular slides and the respect to GINA guidelines does not represent these things, very low dose and low dose. It has to be appropriate dose. That's number one. So there's something like this very low dose, which is budesonide 100 mics plus formoterol 6 microgram once daily. And the low dose is the same thing twice daily. So this is very low dose and low dose.
We don't have 50 microgram inhaler in India. Abroad, 50 microgram inhaler is available. If it was there, it could have been twice daily.
Yes,
but
twice
since
daily.
we have minimum concentration in 100 microgram, so we have to use it once daily when it is very low dose in step 3.
Yeah.
But in step 4 when we go,
and
we can
essentially,
use it twice daily.
adding to this is that very low dose is not to begin with. It is useful in the step down.
In step 3, if I go back.
Okay, step 3 you can use. Step 3 you can use. Yeah. But
it
MART
is mentioned as very low dose
Yeah.
ICS plus formoterol.
Yeah.
See here. Very low dose ICS. I was always wondering what is, and even delegates should know that what is the difference between very low dose
and low dose.
Low dose. So in step 3, very low dose means once daily, and in step 4 you can make it twice daily. So now prescription for Ishan. We have to write a prescription, right?
Yeah,
so
prescription
what
has,
all factors should be
prescription has 3-4 components. One is the hardware. The hardware has to be very clean. Here you have MDI spacers plus your MDI plus spacer. That's your hardware. Then you have controllers in the form of low dose MART, and other options, as you rightly said, is your medium dose ICS plus LABA. And reliever preferred is your budesonide plus formoterol.
Sure, so if you are using MART, reliever is the same.
Same thing. Sir. Yeah. So this is what the prescription I should make it. At the end of the day, what is important is to make the prescription as simple as possible, as doable as possible, and as understandable as possible. Sitting over here is easier, but telling to the patient and making the apply is very important. So this is what the bottom line is.
But even then, the points which are mentioned below, they are important, that avoid triggers.
Yes.
This you have to remind the parents that this is important.
So this last 3 points that has been there, maintain symptom records, very important, asthma diary, daily, PFR monitoring as doable, and step 4 treatment as well.
So you have missed a very important thing, action plan. You must give an action plan to this child.
It will come to that later on. So now Rutuja, who is a 12-year-old girl. Daytime symptoms 2 to 3 times in a week in last 1 month. No nighttime awakening. Remember, there is no nighttime awakening. Her spirometry was done, which showed FEV1 85% of predicted, so mild reduction. FE1 to FVC was also 85%, and FEV1 increased by 15% after salbutamol inhalation. So Dr. Rawat, she requires step 2 treatment. Do you agree? Infrequent asthma, no nighttime awakening. That is very important. And unless there is nighttime awakening, you need not go to step 3, step 4. Am I right?
Yes, I think it 2 to 5 days in a week and no nighttime symptoms, and with a mild abnormality in PFT, I think you can go for step 2.
Now, in step 2, there are 2 options. Either you can give budesonide formoterol, budesonide formoterol anti-inflammatory reliever as and when required, or the older version was daily low dose budesonide with salbutamol as a reliever. What would you prefer? And
now you see, the GINA has made life very, very easy for all of us. They have given 2 track 1, track 2. So track 2 is a track by default. So whenever you have to start, you have to start with track 1. So don't think about track 2 where you have to start with budesonide at step 2 where you are giving low dose continuously. Because why they have divided 2 tracks is because of very, very strong evidence. This all thing has come on the basis of 2 very important trials, say Sigma 1 and Sigma 2, where they have tried to compare budesonide formoterol SOS versus regular salbutamol, regular ICS versus SOS budesonide formoterol. And they found out that the exacerbations, they are much, much less as compared to other 2 arms, whether you are using salbutamol plain or using ICS regularly like in track 2. The incidence of acute exacerbation, they are much less with SOS budesonide formoterol. So the amount of steroid use is less, parents compliance is good, they don't have to give it every day. Second and third, the acute exacerbation, they are much, much less as compared to other arms. So that's why they have divided 2 tracks and they have combined these 2 steps 1 and 2, where at both the steps you can use SOS butyl formoterol. So there is no doubt about it that whenever you are going to treat children, treat track 1 is a default track, start with track 1 only. Very rare cases where parents are adamant or sometimes you don't have access to butyl formoterol, you can go for track 2. But for all practical purposes, track 1 is the treatment of choice.
Now, one more reasoning GINA has offered is that when the symptoms are infrequent, as in step 1 or 2, the adherence to daily low dose budesonide is very less. It is likely that adherence will not be that good. So if you are taking, say, twice in a week, thrice in a week, then it is better to give an anti-inflammatory reliever, where anti-inflammatory drug will also go in wherever you are taking a reliever.
No, sir,
that will not happen in older drugs.
AIR is both things. Like even if you are using budesonide along with SOS salbutamol, you are giving an AIR.
Yeah.
But the compliance is excellent with
correct.
SOS formoterol, and acute exacerbation, they are much less. So if you compare the 2 tracks, the track 1 scores much higher as compared to track 2.
But I am afraid that in practice, general pediatrician, I am not talking about the audience here who is an expert in pulmonology, but the general pediatricians still use budesonide and salbutamol separately, even in older children. I have seen many such prescriptions and they use salbutamol as a reliever. So as early as possible, all the pediatricians should know that track 1 is the preferred track, and always budesonide formoterol combination should be used for all the steps in children about 12 years. Now coming to devices. Now I am talking about children about 12 years. Dr. Jayant, I have shown 3 pictures. So what are your comments?
So as discussed before, MDI with spacer is the most versatile device, and all the guidelines also endorse that. Now for a child who is 12 years, adolescent, slightly, what you can say, uncooperative in regards to following instructions, or they may find some reservations about using a spacer. There are new devices like breath actuated device. What actually happens is that the minute you start inhaling, it's an automated device which releases a fixed amount of dose in the airway, so that the child is more comfortable to carry, and child need not carry the spacer. And there is one more, of course, the good old rotahaler, or what we used to call as dry powder inhaler. And there are 2, there is a revohaler also. But again, in both the cases, though there is a convenience of carrying this device along, and it can be used by the patient at per convenience, maybe carried to school or whatever. The main drawback here is that there is a lot of oral deposition of this medication. So the effective drug delivery would be definitely much better with MDI and spacer. For an older age group now, breath actuated device is a good alternative.
Yeah.
But I think the correct concept is personalized therapy. So you should not be adamant that since it is versatile, you have to do only MDI spacer. Current guidelines, they say that the treatment should be personalized. Give them an option.
Absolutely.
What do you want to use? All three are good because most of them they are going to get controlled by low dose steroid.
Particularly,
and the side effects are very, very less.
Particularly, this is true for adolescents because.
And what I feel is school-going children, if they have to carry a nebulizer to school, then one without a spacer is easier. So breath actuated or a dry powder, including even things like Symbicort, which are much better dry powder inhalers.
But again, there is a limitation that up to a particular age you cannot use them. Beyond a particular age,
older children only. Okay, now we come to follow-up. Follow-up is extremely important in long-term management of asthma. So, Dr. Ajit, at follow-up, what are things you see?
I think the first thing you assess is the level of control, to see whether he is well controlled, partly controlled or uncontrolled. And based on that, you try to figure out why these things are happening. So, this is the way things that you look at, daytime symptoms, nighttime symptoms, on activity, whether use of relievers. If the use of relievers is too high, he's obviously not well controlled. Then you come to why. So the why comes to the adherence in the technique, and the technique is very important. See, since we're giving inhaled drugs, if the inhaled drug doesn't reach the child, then you are not going to get the effect. So you have to review the technique at every episode, every child. So wherever child comes, you have to tell him to get all his stuff with him, his spacers, his inhalers, and review that he's doing it right. Because if he's not doing it right, the patient thinks he's giving the medicine, the parents think, but he's not getting any relief. So that has to be tweaked first. Then you look at the next thing, whether he's taking care of the triggers and comorbidities. Like he might have associated allergic rhinitis not being treated. That might need to be treated. He might have, triggers like they have just got a new pet or something which they are not aware of, or not cleaning up the house. So all those things have to be taken care of. And then review if he is keeping an asthma diary, which is really very uncommon, even though we advise it all the time. And then after all the things are taken care of, then you say whether the medication needs to be upped, down, or just the same thing has to be given properly and reviewed.
Yeah, absolutely. And these are the precisely factors which are also responsible for future risk of exacerbation.
Not tomorrow. I will want to emphasize this one point. I am very emphatic about asthma action plan. Please evaluate that every visit.
At the end. It's coming
every visit
at the
you
end.
have to tell them whether you know it or not.
Every time I take up Dr. Rawat's suggestion that parent and patient should be given in writing the asthma action plan, what should be done in case there is a flare-up or in the case there is worsening of symptoms. Absolutely, your point is well taken. I have mentioned it at the end. Now, adherence and technique, Ajit has already dealt with it. And the most important step in long-term management of asthma is parents should be asked to bring inhaler, spacer, or whatever device is prescribed to the follow-up OPD, and doctor, either the main doctor or assistant doctor or somebody, should personally check that treatment is going on correctly, technique is correct, and it should be demonstrated again and again. And
biggest pitfall is when parents tell you that the child is taking it on his own, I'm not even looking at it. And that is the biggest pitfall.
Absolutely. About comorbidities and triggers, just
no,
quickly,
they are very important, because unless these, now as we all know, allergic rhinitis and asthma can coexist in about 80% of patients. So there is always this consideration that unless and until you take care of the comorbidities, perhaps you will not get good response to your asthma treatment. So all these points are very important. Obesity needs to be addressed in form of lifestyle changes. Food allergy is a very important reason which is often ignored, but sometimes these can be the triggers which can cause severe asthma symptoms. In addition to that, the triggers, as we all know, the indoor and the outdoor pollutants. Most common is house dust, mite is everywhere, fungal molds like damp houses, etc. Smoke, direct, indirect, or even environmental tobacco smoke, all these are very important, outdoor pollens and all. So when you give an inhaler therapy to a child, your discussion should not only end at giving the pharmacotherapy part of it. It has to be also related to the prevention part also.
Yeah. Let me be a devil's advocate, and since we're talking about controversies, Jay, would you advise an air purifier?
Well, actually, I would not advise one, for one simple reason is that air purifier would only be causing purification for a limited thing. And as long as the outdoors air is so polluted, there is no point in using air purifier. You have to use it for every room, which is not practical.
There may be difference of opinion, but we will address it later. Yeah, just a minute. So now, Dr. Rawat, Gina emphasizes assessment of biomarkers in the management of asthma. So are biomarkers really helpful? In GINA 25 says you assess biomarkers. So biomarkers are eosinophilia and FeNO. So what is your take on that?
Yes, I think now the things are changing, the era is changing, and biomarkers have come to stay, and they are extremely important because asthma is a heterogeneous disease. Like if you see under 5 wheezers, they look like all children wheezing same, but they are different. Some children will respond to steroids, some children will not respond to steroids, some are neutrophilic, some are eosinophilic. So it is very important to use these biomarkers, eosinophilia, FeNO, allergen specific IgE, total IgE, and they will really differentiate these children. You can use these biomarkers to diagnose asthma. Like in some case where you cannot demonstrate reversibility, if you have got raised eosinophils and you have raised FeNO, you can tell that child is having asthma and you can start treatment on ICS. They can help you to phenotype. A child who is having high eosinophil count or he is having high FeNO, you can tell that this is an allergic phenotype or type T2 phenotype where he will respond well to your ICS. Then they can help you to prognosticate. A child who is having an acute episode in the last year and you see the high level of eosinophil and FeNO, you can predict that the child will have again a severe attack if you don't control his therapy. So they can help you to prognosticate. So they are very important. They must, in fact, if you see nice guidelines for 2024, FeNO and eosinophil, they stand at the top. As they start evaluating these children, first they do their FeNO, they do the eosinophil count, they decide whether he is having allergic phenotype and they treatment. So nice guideline 2024, these already have been there. So I am sure that in next 1 or 2 years, GINA will also incorporate these things and they will come. So they are very important. You must do it in your.
So the point to take home is that these biomarkers should be assessed even by a general pediatrician more liberally wherever possible. Yeah, now allergy tests and immunotherapy. GINA recommends that sublingual immunotherapy SLIT may be considered in children about 12 years at step 2, 3, 4. There is a mention. How many practitioners advise allergy tests? And how many practitioners advise immunotherapy in your city or anywhere, wherever you practice? So what is your take on immunotherapy?
So actually, as we all know, with a proper counseling and a proper inhalational therapy, most of the children would respond to your therapy. Only in situations where the symptoms are not getting controlled in spite of a correct compliance, correct technique checking and everything else, and if there are any comorbidities which are also there, for example, allergic rhinitis, etc. In such a case, probably one would think of doing a allergic skin test. Earlier guidelines, even in our asthma training module, we used to say that it is more like a clinical diagnosis. So there used to be not much emphasis on the allergic skin testing, but as in the recent guidelines also there is a mention now that in certain cases you can do skin testing, and the skin prick test is the most sensitive test. One must remember immunotherapy is an option which is reserved only in a situation where the child is not responding and has probably only a single allergen which is contributing to asthma symptoms. In which case you can think of using an immunotherapy. Now I think the commonest one is probably the house dust mite, and in which case I think Odectra is the choice. But again it goes on for 3 years. So not that it is not available, but it should not be used randomly. And for doing any other immunotherapy, etc., the child should be in a stable condition. So if a child is having acute wheezing, child is having a FeV1 which is less than 70, probably these are not the children where you do a test and all. Skin prick test is mandatory before starting immunotherapy. So in such a cases, sublingual immunotherapy would have a role inside.
Usually allergic rhinitis, if it is associated with asthma, then immunotherapy gives better results and then it is considered. And it should be correlated clinically. Not on random skin testing, results may be positivity for many allergens, because it should be correlated clinically.
Because a skin test will just tell you sensitization, it doesn't give you a diagnosis.
Now,
very often patients come with a RAS test, panel of tests.
There is acute flare-up, and our intensivist, Dr. Minaz is here, he is just sitting quietly. So just rapid fire questions. What advice you would give to parents before child reaches emergency room?
Well, this is extremely, it is extremely important. If a child is able to take oral, first dose of oral prednisolone at home is very useful, and it is recommended as well. If it is able to take the orally. So you can give oral prednisolone at home.
Second, is there any role for inhaled steroids in emergency room?
Well, in ER, protocol is very clear. it's parenteral steroids. But if the child is able to take, you can give, otherwise parenteral steroid. And inhaled steroids, very limited role.
Yeah, absolutely.
Very limited role. People have been using, otherwise no.
Again, we had a debate in one of the conferences.
As per
some guidelines and some institutes
continue to good, but there is
along with systemic
steroids. But you have to have parenteral steroids.
Okay, which IV steroid is better, hydrocortisone or methylprednisolone?
Methylprednisolone. For the reason that 1, 2, 3. Number one, it has a more anti-inflammatory effects. It has less mineralocorticoid effects. It has more glucocorticoid effects.
At what stage you would consider IV Maxel?
Stage 2. Once you have done like all your SABA and steroids, immediately at ER, we are hesitant to start magnesium sulfate. Earlier the better.
Yeah, I had included step 5 treatment and refractory asthma, but I'll skip that. I don't think we have time. And stepping down therapy, Dr. Rawat, just quickly.
Just the basic principle is that you see it for 3 months, and after that you start tapering down steroid by 25-50% every 3 months. Don't touch LABA.
Only
at the end, when you come to the lowest dose of steroid, then you can stop LABA, and ideally shift them on ICS on butyrate formoterol, because at any age, whether you are treating children from 6 to 12 months, 6 to 12 years or about 12 years, ultimately you have to come down to budesonide formoterol SOS. That is the best thing. So every 3 months you have to evaluate, come down your steroids, and then come to your step 1 therapy, either below 12 years or about 12 years.
So coming to my last slides, the consensus. It was from controversies we have come to consensus. So in children under 5 years, diagnosis of asthma can be made by noting 3 criteria as we have discussed: frequency and severity of wheezing, ruling out alternative condition, and assessing timely response to the treatment. Trial of ICS is appropriate if there are 1 or more acute episodes of wheezing in 12 months, or if frequency of recurrent symptoms is more than twice a week. In children above 6 years, level of control should be assessed. Spirometry should be as well at the time of diagnosis. Treatment started at appropriate step. Anti-inflammatory reliever and MART is the preferred treatment in children about 12 years at all steps. MART can be considered even in 6 to 11 years children, and AIT can be considered at step 2, 3, 4 in selected cases. Regular follow-up is very essential. Current impairment as well as future risk of exacerbation should be addressed. In very few cases, step 5 treatment is required with LAMA, biologicals or OCS. Stepping down the treatment should be as per guidelines, and written asthma action plan should be given to each patient and parent to avoid future flare-ups. Thank you. That's all from my side. Sorry for overshooting the time. And I thank my panelists for very good contribution and thank the audience. Thank you.
I request Shishir sir and panelists to please stay on the dais. I think that was major eye-openers about controversies and consensus, and we've got guidelines, if not rules, to manage childhood wheezing. I now invite Dr. Shikha ma'am, our organizing secretary, to please felicitate everyone, our panelists and moderators. Everyone. Please continue with the applause. It was an amazing session. We learned a lot to practically apply. Please keep the applause going. I wish to welcome very senior faculty, Dr. Kabra sir. Welcome to the program, for pioneer in the field to take the time to attend. Thank you so much, sir. Dr. Mukesh sir, who has joined us, and thank you for joining us, sir. Moving on to the next session, we have interspersed the long panel discussions with very small snippets of small cases, some topics that we find very practically useful, very practically relevant. So the first such snippet is by Dr. Sushant Mane sir. He is Associate Professor and in charge Pediatric Pulmonology at Grant Medical College and JJ Hospital. and is also the zonal head for NTAP. Am I right, sir? I welcome sir to now present his snippet.
ये नहीं आ रहा है नहीं still it's not coming हाँ बस good morning everybody this is audible I don't know yeah thank you so I got a call first from Dr. Uday sir and he said that there is a AIRCON on 22nd you have to come and I said okay then after a few weeks I got a call from Indu madam you have to speak on TB. Till then I was okay. And then she said, you have 10 minutes. So then when we talk about, when we have a TB guidelines, I'll take this. That is better. Hello? Yeah. So this was a 12-year-old girl, fever and cough since 3 months, tachypnic since 4 days, received 3 courses of antibiotics in the last 2 months. X-ray chest that was the X-ray chest of the child. CB-NAT was positive for TB, rifampicin resistance not detected. Severe anemia, 4 grams, came to us with worsening, ventilated, and she died on day 10 of our admission at JJ. The question here we ask ourselves is, why didn't she have an X-ray chest much earlier? What was happening for 3 months? Similar case, 8-year-old girl, fever since 20 days, cough since 1 week, admitted to a private hospital, started on IV antibiotics, chest X-ray had miliary shadows. Rifampicin resistance was detected. The private said we don't have place to keep DRTB patients. The patient was apparently stable. The patients say that they were told to go out, but the private hospital says that they gave negative consent and DAMA, this was a goof up. She was home for 3-4 days, went to multiple municipal hospitals, same story, we don't have an isolation ward for DRTB, not admitted, she came to us gasping and again the child died. Again the question is, could we have prevented this death? So day in and day out we come across, all these newspaper articles that TB is going up, diagnosis is delayed, DRTB is increasing in India, and in children more than half the cases are undetected. The question is, what is going wrong when we have so much efforts from the government side and every side as far as TB is concerned or eliminating TB is concerned. So when we talk about what is going wrong, let us focus upon what are the common things. First and foremost, as we say, more than difficult diagnosis, it is a delayed diagnosis. In 2026 also, children don't get an X-ray when the guidelines say after 15 days you suspect tuberculosis. When you have cough or when you have fever, still we get cases after 1 month or 2 months, not even a simple X-ray test is done. Referrals are late, the prescriptions are so varied. Even if the child is diagnosed with TB, sometimes 3 drugs are started even now. If the child is not responding to the therapy, 1 or 2 drugs are added to the therapy, something like that. So it goes on. Many a times the formulations are not available. No ability for admitting the children. Okay, it is there across not only private hospitals but also public hospitals. Not only in our state but across India we see all these things. Patients are not educated, there is still a stigma, so they don't come up with the symptoms. Even if there is a case in the house, they don't want to get the other people investigated for tuberculosis. No ICU facilities. Most of the hospitals, even in the government or private, government sector basically, don't have adult respiratory ICUs. So leave aside pediatric respiratory ICUs. We don't have pediatric respiratory ICUs, and there are so many factors. So does that mean that we can never end TB? Because that is the goal which we are going forward with as far as India is concerned. So this endgame approach was given by the Central TB Division way back in 2017, when we changed the concept from stopping TB to ending TB, and there were 4 pillars: detect, treat, prevent and build. So I will just brush up each of it. What do you mean by detect is we have to pick up all the cases of TB, and how it will happen is screening all the patients who are having symptoms for more than 15 days. It's very simple. Why were we able to eliminate polio? Because every paralysis coming in to our clinic, even if it was a monoplegia, it was reported as AFP. Similarly, every patient coming with a symptom of more than 15 days, label it as presumptive TB, mandatorily get a chest X-ray done, even if it is extrapulmonary, because 30% of extrapulmonaries will have a pulmonary focus. If the X-rays are highly suggestive, like a lymph node or a fibrocavity or a miliary, go ahead and take an appropriate specimen, either an induced sputum or gastric aspirate, and send for NATs. Now, NATs are the nucleic acid amplification test, commonly known as a CB NAT or a gene expert. But we also have we have True NAT, which is similar to gene expert, which gives your MTB detected and your rifampicin resistance detected. The point here is, don't send a NAT alone, send NAT along with a culture. It is mandatory, that is a liquid culture, because many a times NAT comes negative. After 6 weeks, the culture comes positive. We have n number of examples like that. We had a patient admitted in February, a Kashmiri family came to Mumbai for a visit, just for roaming. The child was ill since 1 month, 1-year-old baby. We did a NAT, came negative. They went back to Kashmir because they were not ready to stay for further investigations. 2 days back, the report has come, the girl is MDR. We have contacted the state TB officer, Jammu and Srinagar, and the patient is being traced from Anantnag district. So that happens. So that is why culture has to be sent. And then supportive investigations. Sometimes your microbiology comes negative, but if your histopathology is showing classical caseating granulomas, that is active TB, or your radiology is suggestive, then also we can say that we are safe in starting treatment. The treat component, now we have only 2 categories, drug sensitive and drug resistance. It is very much simplified. If it is clinico-radiologically diagnosed, not microbiologically confirmed, we start him on a primary drug sensitive therapy. So drug sensitive, it is a 6-month therapy flat for all the cases, whether it is a first time diagnosis or whether it is a recurrent case. 2 months of HRZD, 4 months of HRE, the only exceptions being neuro TB and CNS TB, where we would extend the therapy for 1 year, or the continuation phase goes on for 10 months. DRTB, we have multiple options. Now, the upfront DRTB regimen, which the program advises, is the BPALM regimen. For pediatricians, it is a 6-month regimen. Pediatricians, less useful because it can be given only for children 14 years and above. Less than that, we are not using. So then we have options of shorter regimen, which goes for 9 to 11 months, longer regimen, or a H-mono, depending upon what is our case, what is the site of disease, and what is the resistance pattern which we see. Pyridoxine to be given to all the patients on treatment. Active monitoring for adverse drug reactions, because the children don't report adverse effects. So if you are suspecting, go ahead and actively do a NCV or a visual screening if the patient is on linezolid or something like that. And most important is trace cultures on time. Okay, what happens is we start the therapy today. Just we were discussing, Dr. Bafna was discussing a case where the CBNAT came negative and the culture has picked up H-mono. Okay, or sometimes it happens, CBNAT shows rifampicin sensitive, and at the end of 2 months, the culture comes out to be H-mono resistance. And if you don't pick up till the end of therapy, the patient goes on with the same therapy, and never add a single drug to a failing regimen, which we see still today, even in a city like Mumbai. The patient is not responding, linezolid is added or levofloxacin is added. Prevent is mandatory screening. Once we detect a patient in a family, all the close contacts have to be screened. It is very simple. Just do a symptom screening and get chest X-ray for all. If anything is positive or suggestive of TB, we go ahead and do the complete investigations, diagnose active TB and treat appropriately. If we don't find active TB and the index case is a pulmonary TB case, they go on TB preventive therapy. Now, TB preventive therapy is available for drug-sensitive contacts as well as drug-resistant contacts. So there are different regimens. Again, we would not like to go into detail, but for if the patient is an MDR without an additional resistance, H-mono resistance and a drug-sensitive, we can give TPT. Vaccination, yes, for all the patients, our mandatory BCG vaccination is very important for all the children, as well as, just 2 minutes, as well as for all the children. And now the program is also coming up with the adult vaccination program. Yeah. Adult vaccination program. The pilot study has been done, and very soon they are going to roll it out for high-risk groups in adult. And the pilot study for pediatrics is going to start soon for BCG revaccination. So vaccination is again coming up in a big way. And last thing is the build portion. Get updated with the guidelines. The guidelines are being updated every now and then. They are there on the Central TB Division site, or the trainings happen. Keep in contact with your NTEP staff, whichever is there in your district, because they are very helpful. You just have to call the DTO. They will give all the support right in your own clinic. Train our colleagues, train our juniors, what is going wrong, what is going right. most importantly, capacity building. If we are in a corporate hospital, I should appreciate KDA, that is the Kokilaben Dhirubhai Ambani Hospital. Till 7 years back, it was not a recognized NTEP site. Last 3 years, they went after the program. Now KDA is a recognized NTEP site. So the private patients who don't really want to come to public hospitals can get all the drugs there, and there is an NTEP center there. And then program has provided 5 national center of excellences across all corners of India, and every medical college in the country, okay, is a nodal center. So you will have that much capacity and expertise there to refer the patients as far as difficult cases are concerned. So that was the build portion. To summarize, just success is not final, failure is not fatal. It is the courage, courage to continue that counts. This is a code given. These are all our patients whom have successfully treated. Those 3 are the under 5 kids. We have an under 5 program running where BDQ is not given for under 5 right now in the program. It is only given in Delhi and Mumbai. That is 2 sites in the country. So now they are, I think one is 7 years, one is 6 years. We had started therapy in 2022, and they are all XDR and pre-XDR patients doing very well. Thank you so much. Yeah. Bye.
So thank you, Sushant. It was a very nice talk. And just to remind everyone that we will be having a seminar or a webinar on World TB Day, which comes on the 24th of March, coming Tuesday. And all are requested to join. We'll be sharing the links on the mailing groups. Dr. Sushant, as expected, is a part of the faculty, and it will be informative for all of you. Thank you.
Thank you, Sushant sir. I think if someone could summarize TB. So I've attended sir's whole day and TEP and Pete Palmocon, attended his lectures, but if someone could summarize TB in 10 minutes, I think that was fabulous, and we will all agree. Thank you, sir. I invite Dr. Nehal ma'am, if could please felicitate Dr. Sushant Mane sir. So before we break for share, any insights, practical insights on TB?
I congratulate Sushant for summarizing the whole thing in 10 minutes. But he has given 4 major concerns and 4 major suggestions. First and foremost is go for an X-ray film of the chest. And if some of my age people say three decades ago, it was mainly sputum. So we had to fight with the anti-EP people, and over 10 to 15 years now, that is part of the algorithm. That if you have a cough for more than 2 weeks, fever without any obvious reason, go for an X-ray film of the chest, so that you do not miss those cases. Second thing is that go for a culture, not only CB naught, but for the culture. And it is part of your NT-EP, though specialists may say that it's not required on other thing, but rarer or say precious sample is to be sent for culture, MGIT culture. And what are precious sample? Pediatric samples are precious sample. So this is endorsed by the NT-EP. Third thing is that you go for a TPT. So all age group in a household who are suffering from tuberculosis, who are in contact with TB, after ruling out anti-TB, active tuberculosis, consider them for a TPT, and various regimes are available. And the fourth thing which we are still lagging behind is rehabilitation. So till now we were just treating for 6 months, ठीक हो गया, चलो भूल गए उसको. That is not to be forgot, but follow them up. 50% of children with pulmonary TB may have a impaired spirometry or impaired pulmonary function, and that needs to be taken care. In addition, other social issues like sending the child back to school and other things, that is our responsibility. So now we have to exert, as a pediatrician who are taking care of children, exert that we get all these 4 things on our this thing. Thank you very much.
Yes, I agree with ma'am. Very dynamic and to the point. Dhurandhar 1 and 2 have spoken about TB. Very nice. I request all of you to break for tea right now. We'll take a short tea break, about 15 minutes, get refreshed, and we have the second session waiting for us. We will give a break in between the next session for those of you who want some more and come back. So I hope everyone's all charged up for our next session, which is the 4 Ds, the 4 dilemmas: diagnosis, decisions, and direction, which is going to be a mixed bag. It's a little bit of a break from the targeted case scenarios we have. So now let's see the mixed bag. Our moderator for this session is Dr. Jagruti Sanghvi ma'am, and our panelists for this session are Dr. Shikha Agarwal ma'am, Dr. Rajesh Chokhani sir, Dr. Vikram Patra sir, and Dr. Uday Pai sir. And we look forward to learning a lot more from this mixed bag and approaching more variety of cases that we see. Without further ado, I welcome ma'am and all the panelists.
Okay. Good morning, everyone. We are actually at the brink of noon. And sorry for a little bit of a chaos related to the chai. And I am reminded of a shairi that says that ishq chai ka us tarah se mere dil pe havi hai. इश्क चाय का उस तरह से मेरे दिल पे हावी है कि दिमाग ताला है तो चाय चाबी है. सो एसेंशियली किसी किसी की चाबी अभी तक नहीं खुली है, मेरी खुद की भी नहीं खुली है. सो लेट्स होप दैट दिस सेशन इटसेल्फ विल एक्ट लाइक अ key to the knowledge that we want to look for. The session is called as mixed bag. 4 Ds. That is, see, I'm saying T's. 4 Ds. Dilemmas, diagnosis, decisions, and direction. Now, whenever we talk about learning, we assimilate a lot during our residency, during our teaching programs and all. But essentially, when we talk about the dilemmas that we come across in clinical practice, that is actually where our thinking comes from. And therefore, I am reminded of this quote that says, science is a way of thinking much more than it is a body of knowledge. So we have a body of knowledge in, say, for example, Nelson's textbook. But unless we start thinking, looking at the dilemmas that come into our practice, we are not actually able to implement the right kind of science. Then comes Mahatma Gandhi, who tells us that a correct diagnosis is 3/4 the remedy. So diagnosis is so important in our management of our disease. And then we have Peter Drucker, an Austrian-American author, that says making good decisions is a crucial skill at every level. But Mark Twain bewares us, saying that good decisions come from experience, and experience comes from making bad decisions. So sometimes we may not make the right decisions, but when we have experts like we have today, they would help us tell us what are our bad decisions, and therefore that will eventually become good experience for us to take care of our future cases. And finally, we talk about direction. So whenever we are placed with a case, if we keep our mind like a tunnel, then we do not get any direction. So if you don't change your direction of thinking, then you may end up going where you are heading. So that's what Chinese philosopher Lao Tzu has to warn us. And with these 4 quotes related to my topic today, I will dive deep into the discussion with our first case. So the case 1 is basically a 16-year-old boy, previously healthy with normal milestones, normal growth, presenting with fever since 5 days after coming back from a school trip, cough without any expectoration since 2 days. He was treated with symptomatic treatment by a family physician, but he didn't get better. And then he developed discomfort with pain on deep breathing on the left side of the chest since 1 day, and therefore came to the hospital for an admission. So my question to Dr. Chokhani is, how would you, what are your thoughts when you see a patient like this?
Hi, good noon everyone. Yeah. So this child, this 16-year-old has come with fever for 5 days. So since it's fever for 5 days, obviously it's an infection. We start off by thinking it's an infection. Since it is already 5 days, we start going away from a viral infection. Cough has come up a little later in the illness after the 3 or 4 days, so it's not an airway disease. So I'm thinking of the origin of the cough from anywhere but the airway. And then there is a chest pain, which is definitely suggestive of a pleural involvement. So if I now add everything, it looks like he is going in for a parenchymal bacterial infection which has spread to the pleura and is causing a pleural pain, and the cough fits in there. So at this stage I am looking at it as a parenchymal bacterial infection. Having said that, I would like a lot of details about fever, cough, etc. Yes.
Yeah. So coming to the examination findings, sir, the general condition was okay with normal growth parameters. Fever was 101 with a tachycardia of 106. BP was normal, 100/60. The right nostril showed congestion, not so much in the left side with blood-tinged discharge. There was no lymphadenopathy, rash, arthralgia or jaundice. And on respiratory system examination, there was a reduced air entry in the left supramammary region, but we didn't find any crepitations, and there was no rub on deep inspiration. So, sir, where do we point? Like you mentioned that this looked like a bacterial parenchymal disease. So, what are the things that go for it and against it when we look at this examination?
So looking at this data, the first thing that strikes me is that the fever is just about moderate. It's not very high. Typically, a bacterial pneumonia often has higher fever. So I make that point, note that point. Now, one-sided nostril congestion with blood-tinged discharge in a 16-year-old. My first question is, did he have epistaxis earlier as a child in the past, repeated episodes, etc.? Because this is a little funny complaint. Obviously, it's not the age for a foreign body, etc. So therefore, I don't know the
There
significance
was no such
of
history in the past, sir.
Of epistaxis.
Of epistaxis.
So since there is no such history and this is not the age for a foreign body, that one-sided bloody discharge is a bit fishy, but I mean, I don't know the significance. Okay. Coming to the respiratory system findings, in the early stages of a bacterial pneumonia, my signs would be reduced air entry, that's it. So it evolves over time. Right. So that's okay. Again, a small point that left upper lobe is again a bit of an less common place, but it's possible. So, I mean, I'm saying that in the routine OPD, when you are facing this kind of a case, you would note these small odd things, or maybe you will bypass them, but then you will take it as a routine bacterial infection.
Okay, so at this point of time, we are looking at this as a routine bacterial pneumonia with a pinch of salt. So investigating it further, we found a hemoglobin of 12.5, a count of 7,020 with a neutrophilic predominance, normal platelets, normal SGPT, which Dr. Chokhani will ask me, why did you do an SGPT? But it was done apparently. CRP was 39.5, that was high. Typhoid, IgM, dengue NS1 were negative, considering that the child had gone for a picnic and he was out of town. These were the tests which were done. PS for malaria was also negative, and a blood culture was sent. So, yeah, and of course an X-ray was done. So can I go to the picture, or would you like to comment on this, sir?
So again, the count is not high. So again, one more tiny point for me to question, I was expecting leukocytosis. Absolutely. In a bacterial infection. No. Having said that, it's a 16-year-old, it's possible, not unusual. And then I would keep in mind some bacterial infections where the counts can be normal, like a atypical organism infection.
Again, the age group is also such.
Yeah. However, the cough is much more predominant. Here, you said cough came third, fourth day and was mild. So that's again a small point.
No, sir, it was dry. It was not like mild. It was there. Persistent cough was there, but it was dry.
Okay. And of course, typhoid, IgM, I wouldn't rely on ever. Dengue NS1 was relevant before that. And fine, CRP, I mean, you want me to talk on CRP?
I think all of us have heard, sir, on CRP.
Okay. So I feel it's all, I mean, my anagram for CRP is conditional response permit. CRP stands for conditional response permit. So when there is leukocytosis, I say no, bacterial infection. CRP kabhi normal hota hai, start antibiotic. When CRP is high, everything doesn't point to a bacterial infection. Look, CRP is high, start antibiotic.
Yeah,
so that's our conditional response permit. Ultimately, we want to start an antibiotic.
Okay, sir. So we have an X-ray chest that shows this kind of a picture. And then would you start an antibiotic in this child?
So it's a round shadow. Now, it's not that round shadows cannot be bacterial pneumonias. They can still be simple streptococcus pneumonia, bacterial pneumonia. So it's fine. There are other differentials like a malignancy, a fungal infection, but you said this was a healthy child. No past history of any other illnesses, then I'm not really looking at a possibility of a fungal infection. And similarly, malignancy, usually a patch in the chest would be a secondary from some other malignancy. And therefore, to that extent, if he is a healthy child, I am again not looking at that either.
So then, sir, do we treat this like a community-acquired pneumonia and start antibiotics accordingly?
To begin with, yes. But at the same time, now, one more thing is we have to keep tuberculosis also in mind. Now, that round is not for tuberculosis, but because of the unusual points that we had, no leukocytosis, the fever was not very high, etc. But it looks like a very acute illness. If he was bang normal 5 days back, then I would start treating him with amoxicillin as a community-acquired infection.
Okay. And we would probably give, like because this child is admitted, we would give him IV ceftriaxone or something?
So not ceftriaxone.
Okay.
So he could well be treated on a OPD basis with amoxicillin. But if we admit, then again amoxicillin is good enough.
Okay. So after 3 days, sir, there was a persistent, and now the fever was a little high grade, going always above 101. Increase in cough was there, and clinical findings remained more or less the same. The blood culture by now showed no growth. Hemoglobin was 11. WBC count was 9,200. Again with a polypredominance, 3.2 platelets, and CRP increased further. So now what are your thoughts, differentials, and would you repeat an X-ray at this stage, sir?
Sorry?
There was no rash, no lymphadenopathy to begin with. And in 3 days it didn't change.
So as a general approach of a general pediatrician, whenever if I think something is a pneumonia, bacterial pneumonia, I start off from that point. And 2-3 days down the line, there is no response. My first thing is to look for complications, if any. Second, I would look at whether I have failed to cover the correct germ, whether my spectrum needs to be changed. And third, as a principle, whether I need to change my diagnosis, start looking at something differently. So here, you showed another X-ray where there was no change apparently. So if there is no change, at least what I am looking at is there is no complication. So that is not explaining. Complication like a empyema or a collection or something is not happening. So it doesn't explain my persistence of fever. Change of organism, if I noticed correctly, your hemoglobin dropped a little from 12.5 to 11. Small point in favor of mycoplasma, my amoxicillin will not cover that, whether it's an autoimmune hemolytic anemia of mycoplasma. So I would just think of whether I need to add a macrolide. But I am already started thinking of alternate diagnosis and not a bacterial pneumonia.
So would you do a respiratory biofire?
So upper respiratory samples do not represent the lower respiratory pathology, and therefore I wouldn't.
Okay. Would you would send a mycoplasma IgM and start on, say, azithromycin or macrolide?
Yes.
Right. Okay. So essentially we are looking at 72 hours of appropriate antibiotic therapy, and when that's the time you reevaluate, and like sir mentioned, you reevaluate your clinicals, your labs, your microbiological thought process, as well as your imaging. The X-ray remained the same and did not show any complications. And normally, this is how we would expect our pneumonia to resolve, that the fever should come down in 2 to 4 days, the cough should get better in about 4 to 10 days, the initial tachycardia, tachypnea. So this is the normal way in which pneumonia should resolve, but this didn't. Also on day 4, this child developed that right-sided bloody nasal discharge, actually became like, he developed more blood from there. And now the additional history, we got to know that there was nasal discharge 15 days ago, slightly blood tinged, and there was off and on. When the ENT was shown before he went for the trip, it was diagnosed as some nasal polyp, thought that the child needed follow-up on it, given some nose drops, but he went away for the trip and then came back with these things. So that was never further addressed by the ENT surgeon because they didn't follow up. So this is what has happened to the nasal discharge that we are talking about. Now, because there was no further improvement in this child, a CT scan was thought of. Is that the right way you would think about? IgM or not? IgM was done, which was negative. Unfortunately, I have not put it up in this slide. I think there's been a little bit of jumble up. The mycoplasma IgM came negative. However, the child was put on azithromycin in addition to the amoxicillin clavulinate was given for this child.
So your question was CT scan. I wouldn't do a CT scan at this stage. Before that, I would look at alternate, like I said, even tuberculosis I would screen for. And what am I looking for on a CT scan? So at this stage, I wouldn't.
So basically, we are looking at when we have 3-4 days of fever that goes on, which is with, say, some respiratory features, we are basically trying to look at unusual host factors, unusual organisms, unusual conditions or diagnosis, and therefore probably we have a role of some...
Yeah. So see, CT gives us most usually structural information, and to that extent a USG also gives us a lot of information. So in the pulmonology now, a lot can be achieved with USG which earlier needed a CT. So I don't know whether at this stage I would be doing a CT. When I start thinking of okay, now this is not just not an infection only, at that stage maybe I will do a CT.
So right now you would think of COX first and try and rule
I'm
out...
still figuring out my etiology as to why he is not responding, looking at alternate etiology, considering non-infective, but I'm not yet there to say that it's non-infective. So sir, all of this was done simultaneously, where basically tests were done for tuberculosis, as well as a CT was done, which showed consolidation with hardly any patent bronchi in the left upper lobe. There was surrounding ground glass. Unfortunately, this is the only CT picture that I have right now. There was few mediastinal and hilar lymphadenopathy without necrosis, an isolated nodule in the bilateral lower lobes of the lung, which was query Cox granuloma, and a CT paranasal sinus also was done considering that nasal polyp, which showed a right nasal inflammatory polyp with a grossly deviated nasal septum and bilateral ethmoid right hemisphenoid sinusitis. And at 7 days, we had persistent fever, 1 episode of blood-streaked sputum. Simultaneously, the MAN2 was negative, the induced sputum, gene expert came negative, quantiferon TB gold was negative. So now would you want to start anti-TB in this child? No. Sir, it was done. Ideally, it should not be done. MAN2 test is not done. Yeah, that is what has happened in practice. We picked up a case from real life, sir.
That way, which should not have been.
Sir, the masses are still to realize that MAN2 should not be done.
Yeah. So it is a mistake, but this is what has happened. No, not like it is. Okay, so for an unusual clinical presentation like this, we are of course looking for unusual host factors, unusual organisms, unusual diagnosis like Dr. Chokhani has been hinting from the start, and that probably required an unusual doctor in the scenario, and in came Dr. Shikha Agarwal. So the pediatrician Dr. Tushar Manyar had been dealing with this case, and he continuously persisted on trying to find a diagnosis before thinking of giving AKT or anything in this child. So here is where like all the tests came negative, and therefore what do you think like now? What are your thoughts on this, Dr. Shikha?
Yeah, so first of all, thanks for the organizer, and I'm really feeling humbled to share a dais with Sir here, sitting here. So when a case is getting referred from Sir or Tushar Manyar Sir, so then I'm at that thinking, yes, the first things have been ruled out, and when we are seeing something which is beyond 10 days of fever, then we think beyond something which is a common infection that we are dealing with. So we are dealing with something which is not resolving, so a non-resolving kind of pneumonia. If we really now join the dots, which is very difficult in an initial phase, so if we join the dots, we see that there was some upper respiratory involvement. So we had a polyp. CT is also showing a sinusitis. We are dealing with an adolescent boy. We are dealing with a non-resolving kind of pneumonia where we have given an antibiotic. CT is also showing some lower lobe involvement. So there are some other infiltrates also, not on one part only. And if we see the CT, we are seeing that there is no patent bronchi. So there is no air bronchogram that we find in a normal pneumonia. So with all this picture, when I'm seeing an adolescent boy, of course, we always think in a round pneumonia, like Sir said, malignancy. So we see other possibilities. So malignancy, not considered because of reasons pointed out. If we think of now rheumatological cause, so vasculitis is one thing which I will think in the initial part compared to anything which is like lupus or autoimmune like condition, because the C-reactive protein is also very high, which will happen in vasculitis. So I'll work up in that direction. So of course, like Sir asked a very important question, urine, because you see which systems are involved here. So this patient, I believe the urine was normal.
The urine was normal, the creatinine was also normal.
Creatinine was also normal. So we are seeing upper respiratory, we are seeing lower respiratory, and we are seeing no other organ involvement. So in that light, we'll work up further.
Yeah, so what would you work up? You will do
So most common with this kind of situation, we are dealing with a small vessel involvement. So we will do an ANCA. So a specific PR3 or MPO ANCA should be done by an ELISA method in this patient.
So ma'am, here P ANCA and C ANCA were done which were negative. Anti-GBM antibodies were negative. Could it still be an ANCA related?
So what is the general recommendation now is when you're thinking of an ANCA associated vasculitis, rather than doing an immunofluorescence method, which is P ANCA and C ANCA, a specific ELISA method, which detects the antigen. So that has to be done, which is PR3 ANCA and MPO ANCA, rather than doing which is pattern based. This is pattern based, observer based.
Okay. So this child was basically worked up thoroughly. CT guided lung biopsy was done, sent for histopath, and due to a strong suspicion of granulomatosis with polyangiitis, sample was sent for P3 ANCA because Dr. Shika was involved, which came strongly positive, and histopath further confirmed that it was granulomatous with dense interstitial inflammation with vasculitis, suggestive of ANCA related vasculitis. So ultimately, the eyes cannot see what the mind does not know, and we would like to ask Dr. Shikha to tell us what all should we look for when we are looking at a vasculitis related such feature. So we have this criteria, we would like you to just talk about.
So for any vasculitis, I think this comes very later in the part when we are kind of already diagnosed it and then we are joining it. But I always say that कि जब कुछ समझ नहीं आ रहा तो rheumatology सोच लेने का, because then there are chances that you are not dealing with common infections or something. And normally when you're dealing with autoimmune kind of where we think ANA, we tend to do ANA as a priority, but C-reactive protein usually doesn't rise much in a lupus kind of condition or JDM, and they do not present with pneumonia as a primary feature. So that is one thing. Sir said C-reactive protein, but for us CRP and ESR becomes important. So if I'm seeing that the ESR is high, and
I said with response to antibiotics. I'm not taking it away from rheumatology.
So it stays with the rheumatologist essentially, not with the general pediatrician.
Yeah, so saying that if I see a CRP is normal and ESR is high and I'm dealing with multi-system involvement, not only pneumonia, then I would tend to do ANA. But if I'm seeing an ANA which is high, CRP which is high and ESR also high, so then I think of inflammatory causes, which is like vasculitis, or in other cases like other inflammatory. So here ANCA was done, which came out to be positive, and retrospectively, like we said, we joined the dots. There was an upper airway involvement, there was a lower airway involvement, pulmonary involvement. We proved a granulomatous inflammation, we proved with CT that there was no air bronchogram, and ANCA came out to be positive.
So how would you manage this patient with steroids?
So of course, So with immunosuppression, not only steroid.
Okay.
So that's very important to because unnecessary steroids or undue duration of steroids should not be given. So rule out whatever system is involved. Renal was not involved in this patient. An opthal screen for uveitis, of course, which should be done. And then this child was started, of course, with steroid to control the inflammation initially, and then long-term maintenance. This child, cyclophosphamide was given in this child, pulse therapy. After that, maintenance therapy.
Okay. And then we found resolution of the X-ray findings in this patient. This was after how long of having put the child on methylprednisolone?
Not immediately. I think this must have been done after
2 weeks,
months.
3 weeks.
Not immediately. I think
2 to 3 months.
2 to 3 months or so.
Okay. So the key learning points here is that a non-resolving pneumonia needs re-evaluation and rethinking within 72 hours of figuring out that something is not going right. Always look for systemic clues and cues in other systems. Think beyond TB. EULA criteria, what Dr. Shikha rightly pointed, early immunosuppression can be life-saving. And trust this, that when pneumonia does not behave like pneumonia, it is probably not a pneumonia. Coming to the next
Jagruti,
case.
just one sec.
Yes.
Shikha, which other rheumatological conditions have good pulmonary manifestations which we should know?
So sometimes in systemic onset JI, you can have a lung involvement, but that is in pediatric age group a bit not so common. It comes in the later. Vasculitis group mein, this one GPA is one thing which can have a pulmonary involvement. Even microscopic polyangiitis can have a pulmonary involvement.
Effusions are common. Effusions as in...
Effusions are common with lupus.
Okay.
So if you are dealing with an autoimmune, then serositis is one thing which is common and effusions can happen in that.
Was the bleeding from the nose unrelated?
Sorry, Mukesh.
So I'm not sure. So usually it is this which we show the vasculitis in the lung lesion. That's what. I'm not sure what the polyp would have shown.
Okay. We move on to the next case.
So the bleeding from the nose was unrelated, or was it a part of the vasculitis?
It was a part of the vasculitis. So that's a very relevant question.
Little more examination there probably would have helped us.
Yeah. For that time, if the child would have not gone for a trip and the polyp would have been taken care, and that time investigations would have happened, early pickup
could have been done.
But it's very important not to start COX, like already COX treatment here.
Yeah.
Loculated.
So, okay, coming to the next case. We have a 4-year-old boy who presented with sneezing and runny nose almost daily for 3 to 4 months. I think we do come across a lot nowadays in our Bombay climate. 1 to 2 episodes of fever lasting for a day in between, like snoring at the night for the past 15-20 days, history of building construction all over Mumbai in all adjoining plots for the past few months. Parents say that he always has a cold. He's been taken to various doctors. Many courses of antibiotics have been given. Many courses of decongestant nose drops have been given. And now they think that their child has poor immunity. There are no pets, but he often feeds dogs in his locality. Dr. Uday Pai, can you tell us how would you approach this child? Like, how would you think? What are your thoughts on this?
You're right. I mean, being in tier 1 city and being metro, all the factors which probably we face on a regular basis fall into this. If you look at it, yes, go back to the previous slide. Yeah, if you look at it, there are 3 or 4 immediate pointers. I mean, sneezing and runny nose is something which we probably see so often in our practice, and we realize that probably either we overtreat, undertreat, or if what we heard about the mothers with nebulize at home. So we see all that happen before they come to us. The mother will say previous water given, repeat the prescription. Then in addition to that, there are 1 or 2 episodes of fever lasting for a day or so. So in addition, you start thinking whether it's fever related or something which has triggered off the particular sneezing. You think in that direction. Snoring at night for the past 20 days. Yes, you're looking at a blocked nose, narrowing of the nasal cavity, which is probably due to congestion, probably due to either inflammation or probably due to some little overreaction of the mucosa there. Construction, yes, every neighboring block there's some activity going on. In addition, you have all other factors which probably give the necessity for us to have a bad particulate matter in the air, which is giving rise to the situation. The third is, yes, they have gone to multiple doctors who have given them treatment, maybe with antibiotics, decongestants, and he always has a cold, and they say, yes, either he says that our child is poor immunity, or you're looking at a recurring syndrome, which is probably happening very often, related or unrelated. And today, yes, I mean, there may be no pets at home, but yes, often face dogs in the locality. But yes, we have a lot of families today where furry family member is already existing in the family, which is also a possibility. So there are three things which come out here. Either it's a fever-ish related trigger off, where you think of a small grade lower, maybe a viral infection which are triggered off, that could be a possibility. Snoring gives a sign of a nasal block. Construction, yes. He also has that he has multiple, so recurring in nature. So it may not be related to the trigger or maybe a new trigger. And yes, a dander or a furry dander, animal dander, which can trigger off.
Yeah, trigger.
So we go to the next
ask
stage.
for other histories, sir. So we did ask for a family history of atopy. The mother had flexural eczema, father had morning episodes of sneezing and is all right throughout the day. And this child did have atopic dermatitis in infancy on examination. So basically they said that there was dry skin over the face which settled by 10 to 11 months. So are there any other history that we need to basically demonstrate or ask for?
See, family history becomes very important. I mean, just if you look at it, if there is a viral episode, you are looking at other family members also having a similar viral episode. You know, that's the first thing which trigger off. Somebody in the family also has viral episode, that same viral episode comes to the child. In addition to this, what very specific episode which you're talking about, allergy in the family members, as well as atopic dermatitis when the child was at less than a year. So both of these give you a very clear direction to understand that, yes, there's a family member who has an allergic problem, as well as the child also had an atopy. And if you remember allergic march, yes, we all remember that the evolution of an allergic march is always starts with atopy in early childhood, probably gets into allergic rhinitis, and that probably also gets into allergic asthma, which Shirish talked upon, and saying that this is also something which you keep in mind as the child goes beyond 8 to 10 years, and that's something which also we remember. And this is exactly the course of events which we'll look at. Sure. But in this, the other things which we'll probably try to look at in allergens is, are there any consumption of food related things that the child has been exposed to? Especially with the kind of eating habits that the children have today, they are exposed to so many, maybe chemicals, preservatives, artificial flavors, and multiple things. So which is also something which will come out from the history as to understand how much of the child's eating habits also could be responsible as a possible trigger. So which also will give you a little idea as to whether we are looking at an IgE related or non-IgE related situation.
Yeah. So essentially a very good history is what is needed, and just for the sake of time, I'm going to just brief through the examination. Farafat se, growth was normal in this child, and we looked at the face to look for allergic salute, allergic crease, allergic shiners. These are basically representative photographs, but as general pediatricians like me, it's important for us to look for these when we are looking at a child who comes like this, whom we are thinking in terms of allergy. And of course, there could be an enlarged inferior turbinate. So usually, sir, would this be a clinical diagnosis, or would you like to investigate a child like this? And Dr. Vikram can also eventually put in your inputs on this.
See, most of the time, with the clinical history, first would be clinical diagnosis. But I mean, this was probably what we as, I have another word for CRP, which probably Rajesh will agree, clinically responsible pediatrician. Look at, if you have the patient who is following up with you for a long time, you know the evolution of what the child has undergone. So if the child comes repeatedly, you try to look at, is there something which I am not addressing? And today, we are looking at, if you look at 20 years back, allergy was by elimination. You eliminate everything else and say allergy, and parents also say, allergy hai, theek hai, and probably don't want. But today they want an answer for it. So yes, we'll probably go a little deeper and try to understand what are the things we would like to do.
Yeah, so Dr. Vikram, I am going to just put up all the investigations that we as general pediatricians think of doing, and you can just tell us whether which all should we actually do and which can be completely avoided.
Thank you, team AIRCON and team IIP Mumbai for inviting and giving me the opportunity. So basically, if we are going through the history, this is a typical case of allergic rhinitis. Those fever, intermittent fever, as a normal child can have repeated URTIs, the child will also have URTIs in between. So allergic rhinitis is a clinical diagnosis. So basically, no investigation to prove or to reach to the diagnosis. So whatever investigations are done, they should be targeted to know the allergen so that we can have avoidance measure.
I think that's a very good message, that
Yes.
none of these investigations help us to basically further our management. It is more about, like yesterday some people were saying that IG we do just to tell the parent कि हाँ allergy है. But other than that, there is not significance of these. And I'm just skipping this because I think you've given a very important message that none of these are really needed to diagnose allergic rhinitis, because the diagnosis is mainly clinical, and the reason I'm skipping is because I want to discuss the management part of it. So this is again the ARIA classification. And sir, if you think that this is significant for us as general pediatricians to know, so that it helps our management, you speak about it, otherwise we go further to talk about
this
it.
is very important because history is important in any allergic condition, and so is true for even allergic rhinitis. This is needed to direct the treatment. So if we are dealing with a case of intermittent, which is intermittently present and mild, we need not put the child on some long-term management. But if persistent symptoms are there, moderate to severe, affecting the quality of life, then we need to put on long-term intranasal steroids in such cases. So this classification is useful.
Okay. So then, should allergy testing, what are actually the investigations? You said none of those investigations that we routinely do are needed. So what are the tests that you think we should do? And what are the indications for doing those tests? What are the different methods by which you can test for allergens?
So again, in mild intermittent cases, no test is needed. Just prevent the triggers, irritants. But if it is persistent and moderate to severe, then definitely when you start intranasal steroid, you are going to give for a period of say 3 months. And once you stop, they are going to recur back. Then the next question from the parents will be how long they will give. Because after a gap of 2 weeks, 3 weeks, they are going to have symptoms if it is a perennial allergen. So for our main purpose to go for investigation is to detect the allergen so that they can go for allergen avoidance. So gold standard diagnosis for picking up allergen is allergy skin prick test. And if for certain reason if we can't do, then we should send, rather than sending total IG, we should send serum specific IG for a particular allergen. And in history, one point we would have extensively asked the timing of symptoms. Okay. If a patient is complaining more symptoms indoor, early morning, we'll think of house dust mites. The patient is from Mumbai, tropical, humid weather. We are going to have more than 90% of cases of allergic rhinitis are going to be the house dust mites. Okay. And we can have other allergens also, fungal molds we can go for. If patient complains that after coming out from playing from a garden, then we would think of some grass as a trigger in such cases. So that's how we can select specific allergen to be tested.
So in yesterday's workshop of skin prick test, we learned this partly. So I'm just going to give a gist that the skin prick test as well as the IG is actually picking up sensitization. So the free circulating IgEs are picked up by the specific IgE test, and the skin prick test will basically pick up the IgEs which are attached to the mast cells basically. So that is more specific, and all of us actually went through the entire thing, and we actually had a hands-on demonstration of the skin prick test. Sir, what about component resolved diagnostics? CRD, it is like we have a lot of medical representatives from companies who talk about it. So can you tell us a little bit about it in a minute with advantages, limitations, and which all tests would you prefer?
It's a wonderful test in the basket, but I warn, as CRP is going hit over here, it should not become a CRP now. Because it should not be here, because lab people are promoting it in a vigorous way, and many of us are doing CRD without having the basic knowledge. The CRD is going to confuse you and parents both. So it's a highly specialized test, should be reserved in certain cases. If I'm planning to start immunotherapy, I'll definitely, because gone are the days immunotherapy we used to start and we used to wait for a period of 1 year, no response, we used to stop. Beforehand only we can select the right candidate. If candidate is selected rightly, immunotherapy is going to do wonder in allergic rhinitis patients. So the advantages, yes, there are now different types of tests. Multiplex are there. We have specific components, singleplex. So we generally prefer doing singleplex. If on skin prick test I get skin prick test positive for say house dust mites and cockroach, CRD is going to tell me whether this is cross sensitization, cross reactivity, or it's a true allergy to house dust mites. So DERP10, the tropomycin, they cross-react with each other. So both can come positive on serum-specific IG, both can come positive on skin prick test, but CRD will tell me whether if DERP1 is present, then yes, it's true sensitization to house dust mites, and that is the right candidate to start immunotherapy. So that's why if I want to start immunotherapy, then it is helpful. CRD is basically more important in food allergies and polysensitization cases, not for routinely we should not do.
Okay. Sir, if a child is already on antihistaminics or on intranasal or oral steroids, would you go ahead and do any of these tests?
So for skin prick test, we need to stop antihistamine for a period of 7 days. For other tests, it is not needed. We can do skin prick test even if the patient is on intranasal steroid or inhalational corticosteroids.
Okay. So the child underwent an allergy panel test.
Which should not be done.
Okay, that's like the CRP again.
Yes.
So it turned out to be positive for house dust mite, cockroach allergen and dog dander. So like you mentioned here, this is the place where you would do a CRD, and that might help us to basically decide whether it is true sensitization or not. So here, sir, if in Bombay we want to just look for common Mumbai allergens for a specific IgE or for skin prick, depending on what is our ability to do the test, then what are the common Mumbai allergens to test?
House dust mites is the most common, already mentioned. We have 3 species, but serum-specific IG is done for 2, Dermatophagoides farinae and Dermatophagoides terrorinicinus. And we can send, if the symptoms are more towards the evening, night time, before bed, then I would like to consider cockroach. If pets are there at home, parents don't want to leave the pet because they will prefer leaving the doctor rather than leaving the pet. So in such cases, you can show them that the child is sensitized to cat or dog. So they may get sensitized to leave the dog or cat, or still they can leave you. But fungal molds are the second most.
Okay. So we have, of course, allergens avoidance. So can you just brief a little about pharmacotherapy? More importantly, I want you to tell us about all the different intranasal steroids available, which are the which is the composition that we should use, how long, tapered or stopped suddenly? Can you just tell us?
So allergen avoidance, dust mite avoidance helps a lot. Pharmacotherapy, again, the most common oral medicine, what we should prefer, if phenotype is Nizar phenotype, mild, intermittent, oral antihistamines, SOS basis, second generation antihistamines are preferred. Fexofenadine, cetirizine, levocetirizine, loratadine, desloratadine, bilastine in this thing, we can prefer giving. Montelukast as a monotherapy for allergic rhinitis is not at all recommended. We should not promote it. When coming to intranasal steroids, we have 3 choices routinely used: mometasone furet, fluticasone furet, and fluticasone propionate. Fluticasone propionate should be used above 4 years. Mometasone furet and fluticasone furet both are good with low bioavailability, can be used above 2 years of age. The affinity for the receptors are best with the fluticasone furet. But the bioavailability wise, systemic absorption is less with mometasone. But they are just marginal difference. Either of the medicines we can use. Coming to the recent combination, most of the companies are coming with fluticasone and oxymetalazoline. We should never use. Because once that is there at home, parents will tend to give that. So if we want in the acute stage for 3 days, 4 days, it's okay. We can give separate oxymetalazoline, but we should not use this combination.
Because of a risk of rebound congestion.
Yes. And atrophic rhinitis also. So medicamentosa. Fluticasone azilestin above 12 years. A step upgrade like we have GINA steps. We have even allergic rhinitis not getting good control with standalone INSS, then we can add on local antihistamines like azilestin.
Fine. So and when
the duration, yes, if it's a blocker, perennial symptoms, the child will require for prolonged period. Maximum we should give for a period of 3 months. Symptom remission will be there within 3 to 4 weeks, and let them continue for a period of 3 months. We can have a gap of at least a 15 days gap, and then if symptoms recur, then we need to restart. And there's the parents are going to ask questions, then further things are to be done.
Okay. I think we'll go with the key take-home messages from today's. Sir, you could just, all of these I've mentioned, but consider allergen immunotherapy in selected cases. Like this particular child probably was a candidate for allergen immunotherapy, and what best was to refer to specialists in our own field and we can go ahead
Allergen
and ask for
immunotherapy, I
that.
would like to, the child is 4 years of age. In India, SCIT is recommended above 6 years of age. Recently, sublingual immunotherapy above 12 years they have recommended, but we generally give above 6 years of age. We can give immunotherapy to such lot of advantages. Symptom remission will be there. They will not be dependent on intranasal steroids, and most importantly, it prevents neosensitization. So if we go for skin prick test, initial days we are going to have indoor allergens. As the child goes outside during adolescence, they will start having pollen allergens also. Then it becomes difficult. So if beforehand only we start, then neosensitization can be prevented. In a significant population of allergic rhinitis, adult onset asthma develops. You showed in that atopic march. So it prevents even asthma development in future.
Okay, so yes, allergy immunotherapy. So this child probably will continue on intranasal steroids, control for another 1 or 2 years, and then eventually think about doing an immunotherapy.
So in our clinical experience, those who are using immunotherapy, we say wait till 1 year. The child may require pharmacotherapy for 1 year, but our clinical experience, after a single cycle of intranasal steroid or maximum 2 cycles, they don't need.
Okay. And as old timers, I think one strong message we will send: don't use combinations. Combinations do not help, whether it's montelukast with levocetirizine or similarly fluticasone with azolastine. I mean, they do not have any advantage as combination. So I think that's another strong message we can send across.
Yeah. So thank you so much for a very, very interesting conversation with our experts, and a big round of applause to our panelists. Thank you so much.
That was truly a mixed bag, and we saw real life approach to a diagnosis and learning from clinical rounds. Thank you, Rajesh sir. Thank you, Uday sir, Shikha ma'am, Jagruti ma'am, and Vikram Patra sir, of course. I invite our organizing chairperson, one of our organizing chairpersons, Dr. Sushma ma'am, to please felicitate our moderator, Jagruti ma'am, and our esteemed panelists. Ma'am, could you please felicitate Dr. Rajesh sir? Dr. Uday Pai sir, Dr. Vikram Patra sir, Dr. Shikha ma'am, and Dr. Jagruti ma'am. And I think we can give a bigger round of applause because they're the organizing team and office bearers for AIRCON. Thank you so much for giving the opportunity to us for this. So I think that has opened the gateway. We've spoken about allergies and immunological disorders. We've spoken about the nasal polyps. So no better now than talking about the entrance to the respiratory system. And this will be none other than, by none other than Dr. Indu Khosla ma'am. Ma'am is Head of Department Pediatric Pulmonology here, and I thank ma'am for the opportunity to introduce her. And please ma'am.
Mic
hand mic.
Yeah, point. Hello. Okay. I think we have. Thank you so much. I think all the sessions are really rocking and learning a lot. Apart from talking, I think I'm learning a lot, and this has been a great opportunity for me to learn. When we talk about the respiratory tract, presentation, we very often forget the upper airway, and I feel the upper airway is always given a stepmotherly treatment. And as general pediatricians and even pulmonologists, I think we have to now give more attention to the upper airway. With changing times, with air pollution, the upper airway has come to stay, and many a times when you look at the upper airway and you forget to look at the upper airway, the problem may actually be above and not below. So I feel I want to kind of showcase a few things where we need to now give more importance, or maybe at least equal importance, to the upper airway as we do to the lower airway. Thank you so much. Okay. So that's why I thought entrance to the respiratory system was a correct kind of a title. So why is it important? Because sometimes it will give you clues to the diagnosis of the lower respiratory systems as well. So if you have allergy, you have involvement of the upper and the lower. If you have mucociliary problems, you have involvement of the upper and the lower. If you have autoimmune, as the case that they just discussed, the vasculitis, the clue was in the upper airway. Maybe one could have thought in the previous case that the problem is autoimmune right from the clue sitting in the upper airway. So when you have involvement of the upper airway, when you look carefully, your clues are sitting there. An untreated upper airway can be a trigger to your lower airway. An undiagnosed upper airway may lead you to a wrong problem, and which is actually in the upper airway and not in the lower airway. So I feel this is the thing we very commonly do. Noisy breathing, what we tell the parents, physiological, it will resolve. We start our newborn counseling like this, which is correct most of the times, but it could be a malacia, an airway malacia. Recurrent V's, asthma, bronchiolitis, under 5 V's, under 6 V's now that they call it, but it could be a vascular ring and it could be a subglottic stenosis. I remember a case that we had in our PICU who came like a bronchiolitis. We identified a Boca virus, child settled, was shifted to the ward, but the noisy breathing didn't go. And the parent kept saying no noisy breathing. And then we did a scopy and it was a subglottic stenosis, okay? Feeding difficulties and desaturations. We need to understand our mothers a little better and be, kind of responsive to their complaints. So it could be a simple silent reflux, and we discussed in Dr. Subhash's session about aspirations. It could be a GERD, but it could also be a laryngeal cleft, and we need to be mindful of that. Recurrent pneumonia, we could think of immunodeficiency after having ruled out everything, but it could also be an H-shaped fistula, or it could be any other aspiration from wherever. It could be from above, below, and that was amply discussed in the first session. Chronic rhinorrhea. We have the esteemed panel here which spoke on allergies, virals, recurrent virals. We always wave it off to say, ye viral hai, or ye allergy hai. This is a standard thing we keep telling our parents, and the parents will come and tell us, again viral, again allergy. But you may be mindful that you could have an abnormality like a choanal stenosis, or even a polyp sitting in the upper airway, which could be a marker even of a lower airway mucociliary disorder. A hoarse cry. Your child shouts a lot. That's why your cry is hoarse. But it could be a vocal cord palsy, which has been missed. So this is something which I thought I would love to share. And when we have these complaints tomorrow with our patients, maybe we should look a little deeper and at least not pass it off if it comes recurrently, right? So the upper airway starts from the nose, the paranasal sinuses. We have the pharynx, which is divided into the naso, oro, and the laryngopharynx. And of course, you have the larynx, which is divided into the supraglottis, glottis, and the subglottis space. So this is, by definition, your upper airway. Now I'm going to make you hear a few sounds, right? So this is a stridor, a classical stridor. Inspiratory, expiratory, biphasic. We have already discussed that. So inspiratory, we know it's coming up from above the glottis. This needs to stop. Or it could be at the level of the glottis, which could be biphasic, or below it could be expiratory. Now look at this. And in my practice, I've seen a lot of such children who come breathing like this. Okay? Sorry. And these are all cases from my clinic or the ones which we have managed. I went back. Okay. So look at this. Now you will see, and you will definitely think probably the problem is in the lower airway. But here, the problem is in the upper airway. These are the children with upper airway obstruction, which are struggling to breathe. You may hear a stutter because of lot of secretions, or it could be even a snore. Okay, but here many a times, and you will have conducted sounds in the chest, and you will think it's a lower airway problem. But look carefully, and in the recent years, the n number of children have stopped inhalers for such children, and the problem was just adenoidal hypertrophy or something involving the upper airway. And of course, you could have a standard wheeze, or a grunt in a very severe child, where it is definitely coming from the parenchyma of the lung. Okay? So this is very important, and you should have something called as a SPECS approach. When you look at airway obstruction, you look at the severity, whether it's mild, moderate or severe. Look at how it is progressing over time. We know laryngomalacias over time become milder. You look if there are associated feeding difficulties, history suggestive of choking. Many kids, I don't know, I think Dr. Kabra will enlighten us whenever we talk to him, but many kids these days have a lot of sucking issues, swallowing issues. There are much more, or maybe we are identifying more of them. But if there are difficulty in swallowing, it could be aspirations. Look at whether the child is having failure to thrive. C is for cyanosis, any acute life-threatening episodes. Look at if it is disturbing their sleep. Not because I work in the field of sleep, but it's very, very important because it will give you clues to what the problem is. And look for any suprasternal chest retractions during sleep. It could be a sleep apnea because of any upper airway obstruction. Okay, now not only don't only look at the upper airway, but look at a general examination because there will be clues there as well. So if the child has got failure to thrive, look at his craniofacial features, a retrognathia, a micrognathia, a midfacial hypoplasia which could occur in Downs, dental malocclusions. And if you have a child with long-standing, like a OSA because of adenoids, you will have their faces which will change and it will become much longer. Look at the tonsils, look at the nasal cavity. Look at CNS, tone, hypotonia. That could also mean some kind of a malacia on top, maybe a pharyngomalacia. So do a complete examination, do a complete ENT examination, do a full cardiopulmonary assessment. Long-standing OSA can have pulmonary hypertension. You could have features of severe heart failure as well. Of course, look at the chest and a complete overall examination of the CNS and behavioral screening. So ADHD-like symptoms could probably be secondary to a sleep-disturbed child. It could be primary, but it could also be secondary. Now, if you look at the congenital anomalies of the upper airway, okay, majority are laryngomalacia, but you could have vocal cord palsies, you could have subglottic stenosis, webs, atresias, hemangiomas, laryngoceles, cysts, and you could have rarely laryngeal clefts, clefts in the larynx. So generally this is the way, the percentage-wise, what is more common when it comes to congenital anomalies. In a lecture of 30 minutes, which I'm planning to make it to 25, I obviously cannot discuss all the anomalies, so I've restricted myself to showcase a few anomalies. And there are a lot of acquired anomalies as well, which I'm not going to dwell into. Now, depending on the age and what age the child presents to you, whether the child presents at birth or maybe from 2 weeks to 4 weeks or at a later age between 1 to 4 months, also you can have some clue to the diagnosis. So at birth, you could have coronal atresias, you could have congenital cysts, webs. So all the congenital problems obviously will come very early. A child who has had a difficult delivery, a breech extraction, could have a vocal cord palsy. A little later, mind you, laryngomalacia does not present at birth. It takes up to around 2 weeks for the stridor to start coming in. So if you have a child who's having stridor, inspiratory stridor since birth, look beyond laryngomalacia. Very severe one can of course present at birth, but generally you should keep your minds open to any other anomaly. Then a little later, you could have a subglottic stenosis, a subglottic hemangioma. If a child has hemangioma elsewhere, think of an hemangioma of the airway if the child has come with stridor. And if a child is older, you could have more acquired problems, like a croup, a hypertrophic adenoid, foreign body, papillomas, etc. Okay. Now also look what are the aggravating features. Right? If it worsens on crying, feeding, you're looking at a malacia or a vocal cord palsy or even a subglottic stenosis. If it worsens during sleep, it is the nasopharynx which is a problem. Maybe it could be a prolapse of the epiglottis, it could be retrognathia, adenotonsillar hypertrophy, the most common. If it worsens on swallowing, that means it could be a vocal cord palsy. So these will also give you clues of what could be the diagnosis. Body position, you put the child prone and it gets better. You're looking at a cyst or a laryngomalacia or a gnathia, micrognathia, or a macroglossia which is now opening up. Okay? And if it kind of decreases or worsens noisy breathing in a lateral position, it could be a unilateral vocal cord palsy. Now coming to a few cases. Now this was a full-term LSCS, no history of birth asphyxia. He had respiratory difficulty immediately after birth. And we were not able to pass a feeding tube through both the nostrils. On examination, if you can clearly see, he has dysmorphic faces, he has slanting eyes, he has the retrognathia, he has low set ears, he has some tags there, and he had severe suprasternal indrawing. Thoughts here, anybody? So this is some syndrome, and we could not pass the feeding tube through the nose, okay? So that we were trying to look at going to the tube, and we were trying to look and what we could see, okay? So you can see here that here you can see a blind end when we are trying to go through the nose. One side is your septum, the other side is your terminates, and you can see now very clearly the end is blind. So what is this? Corneal atresia, okay? So this is what unilateral corneal atresia looks like, the one on the right here, okay? So this is patent, this is blocked. But this is what a bilateral. Typically, what you will get a child who cries, opens his mouth, and the cyanosis disappears. So this is the time you need to think of corneal atresia. Unilateral may be missed because the child has the other nostril. It may become pronounced if he gets upper respiratory infection or a nose block. So we must be mindful of the fact that we can miss a unilateral corneal atresia. So some theory, I think I'm going to skip this because this you can get from any textbook. So I'm just going to skip it for the need of for want of time, right? Now, many of these syndromes are they are associated syndromes with upper airway anomalies, and these are the standard set of kind of syndromes like Charge, Treacher-Collins, Crouzons, DeGeorge, Downs, which would have a lot of upper airway anomalies and midfacial malformations. Now, if you do a CT scan in these children, you will see that there is no pathway here. This is the nose, and this is all blocked. It could be bony. It could be membranous. So you can see it's completely blocked. So that's how you will confirm the diagnosis of a corneal atresia. Now look at this child. This was a 2-month-old. He had failure to thrive. He's still at birth weight. And look at him. He's trying to breathe. And then he opens his mouth to breathe. So what could this be? So it could be unilateral corneal atresia. But you look at this. Here, the obstruction is somewhere else, okay? And normally, this is the obstruction of the pyriform fossa. Normally, you need an aperture of more than 11 millimeters, all right? If the aperture size is small, this is the inlet of the pyriform fossa, which is obstructed, okay? And these are children, this is called the congenital nasal pyriform aperture stenosis, and this arises because the maxilla overgrows into the nasal cavity. So it is more anterior. Corneal atresia is little more posterior. And if you do a CT scan and the aperture is less than 11 millimeters, you will diagnose a congenital nasal pyriform aperture stenosis. It can have associated features like a solitary median maxillary central incisor. Later on, of course, this is an other kid. Or it could have other CNS abnormalities, holoprosencephalies, etc. Okay? Now this is how you differentiate. Okay? You have a corneal atresia posterior. CNPS, more anterior narrowing. You may have a severely deviated nasal septum. You will examine, you will come to know. And I had a child with such a severe DNS, and he came to me with an obstructive sleep apnea. And we did a sleep study, he could barely sleep. And we thought it could be something else, but it was just DNS and nothing else. Okay? You can have nasal dermoids and encephalocele, which can cause a mass lesion. And these are your differentials when you're looking at the nose. Okay? Now this is a kid who was in the NICU and who was on a cannula for very long. So what happened? There was necrosis and this whole thing went away. And the nose itself collapsed, and that was causing his obstruction. So these are things which can also occur. Cannula, nasal cannula pressure, necrosis. You can reconstruct. Reconstruction. Okay? Now look at this. Now this is a baby who presented with 1 month old who presented with discharge from the eyes, relapsing dacryocystitis, and a unilateral nasal obstruction. What could this be? Okay, so this is a very common condition. We always ask them to massage the nasolacrimal duct. So this is a cyst. Now right from up to down, the cyst can be anywhere. And this is prolapsing into the nasal cavity below. If it's unilateral, at least the child will be less symptomatic, but you could have it bilateral. This is a nasolacrimal, congenital nasolacrimal duct cyst. Okay, now this was a 1-year-old, mark the age, who came with nasal obstruction, mouth breathing, difficulty to suck at breast, prefers to sleep in the mother's lap, had poor weight gain, other milestones were normal, okay? And he was actually snoring away at night, okay? Now this is a 1-year-old, and I've lost count on the number of kids I've seen below the age of 2 years with huge adenoids. Look at these adenoids here. Okay, huge adenoids completely blocking the nasal cavity. Now, guidelines say we should remove them much later. Should we remove this early? I tried to search for literature. There is a lack of literature on what should be the correct age of for these children. Now, these children are struggling to breathe. They are all of them having severe nose block. And I think post-COVID, when the lockdown opened up, there were so many infections. I think the adenoid tissue has taken a toll, and we are having a lot of children with large adenoids. So this could be grade 1, grade 2. This is a Cohen's classification. There are multiple classifications for adenoids, but I think there is gaps in every one. So from grade 1 to grade 4, depending on the size of adenoids. Having said that, the size of adenoids and tonsils really do not decide the level of obstruction, and you need to either look at it clinically or do a sleep study, okay? Now this was an article which I couldn't find any, so ChatGPT prompted me this article and I could search this out. So this was published in 2020, which looked at adenoid removal in very young children and whether it is harmful and whether this was the only study they looked at post-operative, whether the child required inpatient admission. So these were children below the age of 3.5 years, 353 children with obstructive symptoms. They divided their age group into 3 categories, below 1.5, between 1.5 and 2.5, and the other third category up to 3.5. Okay, and they looked at post-operative. So they've operated these small kids. And they looked at post-operative respiratory complications when they removed the adenoids below the age of 3.5 years. So they found that there were not many significant respiratory events after removing adenoids early, but you need to admit them if you have smaller children, if their age is less than 1.5, and if they have moderate to severe OSA, or if you have done a PSG and the PSG is abnormal, these kids need to be observed because they are having a long-standing OSA. So there was no single universal minimal age for, I'm not talking about tonsils, I'm talking about adenoid removal. And the decision depends on how the child is clinically, and if the child has got significant airway obstruction and sleep apnea, we can even do it in infants, was the summary of this article, all right? Now this was a 14-year-old child who came to us recently, disturbed sleep, was sleeping in odd postures, he was snoring, mouth breathing was noticed by parents since the last 4 to 5 years. He was never fresh in the morning, and he was occasionally having daytime sleepiness. And the child said, I have no energy through the day. Initially they passed it off, ki adolescent hai, and they passed it off like this, right? When we examined him, we only found there was a DNS, and we found that he had just small tonsils, grade 1 tonsils, and nothing else was there. So he was stockily built, but not really obese. So we, just as DNS, grade 1 tonsils, we advised a sleep study because of his symptoms or of an OSA. So his AHI came as 25 per hour, and we planned to start him on CPAP. We took an ENT reference, we advised him lifestyle changes, but clinically we really could not see much of tonsil adenoids. So we first thought we'll put him on CPAP. Even the ENT colleague said he's okay. So we put him on CPAP for 2 months. He came back that he was not better. At this point of time, we planned a DICE, okay? So many of these children who have large adenoids, if you see, they'll have lot of muck and mucus when we go into them, because there is something called as a concept called as an adenoiditis as well, because there's a chronic infection. So you see a lot of mucus in the adenoid area. And you go past that, he had, this is a very nice DICE that we did. DICE is drug-induced sleep endoscopy. So there were adenoids, and we went down further, okay? When we do use DICE, we make them give them enough anesthesia so that they're just in a sleep state and not in deep sleep. So it mimics what happens to them in real life when they are sleeping. So when we went further, we saw the tonsils, they were very small, but they were completely closing the airway. You can see here, they were completely closing the airway. And we went further down, on the top of the epiglottis were lingual tonsils, which are also pressing the epiglottis. So this kid, then we had to actually, we referred him to our ENT colleagues and he underwent surgery, okay? And these kids you need to follow up. Even if you remove tonsil adenoids, 30% will still have problems. You really need to follow up. Quickly taking you through the supraglottis and the laryngeal inlet. I think I have 4 minutes left. I will show you more videos rather than talk about it. So you have a whole list of things that can happen in the supraglottic area. Now this was a kid who was failing to thrive. This child came to us from Vapi at birth weight of 3.5, 4.5 when he came to us at 4 months. And this is how he was breathing with lot of retractions. Any guesses? Yeah, that was a differential, but he started having stridor early. It was actually a very severe laryngomalacia. That could be a very close differential. Now you look at the epiglottis. This was done by Dr. Anju and Dr. AC from our team here. So you can see the epiglottis, which is completely closing the airway. So this kid could barely breathe. So this underwent a supraglottoplasty. This child is doing well. He's on follow-up for the last 3 months. So these are your different levels of laryngomalacia. You could have the arytenoids flopping in, or you could have the epiglottis folding up like an omega-shaped structure, or something as severe as this, where the epiglottis is completely shutting the glottic opening. Okay? Now this was a kid again who came to us from Gujarat. This was a child who started stridor since 3 weeks of life and significant failure to thrive. Okay? Now when we went in here, we were expecting to see something different because this child was looking only different. So she had a large hemangioma, which is starting from the subglottic space right up to the lower end of the trachea. We put her on propranolol. On follow-up, she has gained 2 kg and she was doing very well. So they do very well. You have to start propranolol early as the hemangioma is growing, and you may need to continue it for a little prolonged period of time. If you have a hemangioma in the beard area, there's a 50% chance that you'll have a respiratory hemangioma. Now this was a child who presented to us. Look at the vocal cords here now. This is a vocal cord palsy. So this is a bilateral vocal cord palsy. I will take you to this, and you can take pictures of this. Unilateral versus bilateral vocal cord palsy. The bilateral vocal cord palsy is a good voice. Inspiratory stridor may start later, okay? Because they still manage, all right? Both cords are paramedian, so and they don't even aspirate, vis-a-vis a unilateral cord palsy. The reasons for a bilateral could be neurological abnormalities like an adenal malformation, etc. Unilateral is more iatrogenic, following a surgery, a breech delivery, or it could be idiopathic, it could follow viral infections. So many of them can resolve on their own, but especially unilateral can resolve. The prognosis is generally good. You need to give speech and voice therapy, and sometimes you may have to medialize it to reduce the risk of aspirations. Okay? And here in bilateral, you may need a tracheostomy. I have just 2 cases and I will finish it. I'll just stop the cases, right? Now, this was a child who was being treated as an asthma. Okay? What is this here? So this is a laryngeal web. Okay? He's coming as recurrent cough. So sometimes a scopy is very important to see what your, sorry, this was the one, sorry, subglottic stenosis, laryngeal, next one. So if you go back here, I just missed the history. So if you went through this is the direction of the scope, therefore it was looking like a web. Now if you look at here, there was a narrowed subglottic space. The subglottic space is the narrowest part of the airway. And if you have stenosis, it becomes more narrow, and this was a subglottic stenosis. Okay. So this is a Cotton-Mayer classification. You need to treat it only if it is grade 3 and above. Grade 1 and 2, generally children can still do well, and you may not need to intervene. I'm going to skip some of these cases. These are webs. I will show you this case, which looked like which was a papilloma. So you can see the papilloma jutting out from the So now with the advent of the cervical cancer vaccine, these are very difficult to treat. They keep recurring. You may try surgical debridement or intralesional cidofovir, but it is very difficult. These were two syndromic kids we had. This is a child with fever syndrome, and this child had something called as a tracheal sleeve. The whole trachea is one set of cartilage. There are no rings at all. Whereas this is one child who's still currently with us in the ICU. Towards the end, the child has tracheal rings. So the lower third had tracheal rings, but the rest of the trachea was okay. And this one, if you look at the first one, there are no rings. This whole thing is cartilage. She's currently following up with us. So we are watching and seeing the outcomes are generally not good. Now this is my last case. Now this is a kid, 14-year-old boy, who came to me with headaches. And do not forget this, because this is very commonly missed. Came with headaches and nothing else. And he actually came to me with the CT scans. Now look at the CT scan. He came to me with the CT scan. You can see the frontal sinus is very small, and the maxillary sinus, the ethmoid sinus, the sphenoid sinus, all full. So simple sinusitis, okay? Then he also said, I've done a CT chest. Then he showed me the CT chest, because he said, I get cough on and off, all right? And when he showed me the CT chest, there was no clear bronchiectasis, but if you see the upper lobes, this is not normal. So there is some endobronchial spread of infection, lot of nodules. Then he pulled out, if you could see even on the CT, the heart was on the right side. And then a simple X-ray chest, cartilaginous. So these are things which are missed, and this is a 14-year-old boy not diagnosed. So I would leave you with, in your OPD, listen to the child's breathing, listen to the mother sometimes, observe the feeding, position change test you must do, check the growth chart, always ask for history of intubation. Subglottic stenosis can be acquired. And birth history matters, whether the child was yanked out, a breech delivery, a vocal cord palsy. Okay? And all striders are not laryngomalacious, and all laryngomalacious don't need scopy, but airway scopy is a gold standard to diagnose any of these airway abnormalities. Now with the advent where bronchoscopy, yesterday our workshop was full of people who are enthusiastic to do a lot of scopies. I think we have now more and more access to scopies, and we must utilize these facilities to give better service to our patients. Thank you very much. Did I take too much time? No.
Thank you, ma'am. Thank you, ma'am. As usual, ma'am, I request Dr. Rajesh sir to felicitate you. I think we will take all the mothers, sardis, and mere bacche ko snardi ho raha hai. We should take it more seriously, probably. It is our bread and butter after all. Thank you, ma'am. At that, I hope everyone has energy for a quick snippet of 10 minutes before we break for lunch. Thank you all for your enthusiastic participation so far, and I welcome Dr. Rajesh Kasla sir, President of our Mumbai IAP. Thank you for the opportunity to have this event, sir, and I invite you to start.
Thank you, Dr. Tanvi. Am I audible?
Yes.
Yeah, so this 10-minute snippet is on irrational therapy in pediatric pulmonology. It is equivalent to the 10 minutes nebulization that we give, which is targeted to relieve you all of the intellectual bronchospasm if you all have right now. So why this topic matters? We all know that in our pediatric OPD, pediatric respiratory illness forms the major part of our practice. Along with the scientific advances, we are witnessing a parallel rise in the use of irrational therapies treatments which are unnecessary, unsupported by evidence, and potentially harmful too. Now, what is irrational therapy? Medications that are used with unproven efficacy, medications with unfavorable risk-benefit ratio, incorrect drug dosages and delivery, and polypharmacy, that is the fixed drugs combinations that are there. As we treat all these patients in the OPD with the respiratory infections, upper respiratory bronchiolitis, childhood asthma and chronic cough, we land up doing this irrational therapy. Now, why do this irrational therapy, why practices persist? And indirectly, even I am part of it. Many times we have this diagnostic uncertainty of the diseases that we are dealing, and there are high parental expectations. prescribing a drug is easy, but not prescribing a drug and explaining them that why you are not prescribing the drug is much harder. So in the quest to satisfy the parents' anxiety, we should not compromise the scientific rationality of the treatment. Time constraints in the busy OPD also is a problem. And of course, the pharma industry are there to influence us what medications to be used. And lack of guideline awareness also is responsible for irrational practices. So in this 600 seconds snippet, I was supposed to cover irrational prescriptions. I can restrict only to 5 of these because there are a lot of other irrational therapies in pediatric pulmonology. It is impossible to cover all of them. So today I am going to highlight upon those few irrational prescriptions and why they persist and how we pediatricians can change this narrative. So these are the common 5 prescriptions: antibiotics, combination of cough syrups, nebulizations, Montelukast, etc. I will come to it one by one. So the first and the most common irrational use is the use of antibiotics in pulmonology. Viral upper respiratory infection is the commonest one, where the use of azithromycin for 3 days is the commonest irrational practice. We all know that 95% of bronchiolitis are viral in nature, and here we will end up using something called as precautionary antibiotic, which doesn't help anyway. It doesn't prevent the secondary bacterial infections that we think of. Then the second part, the third one is the VOLRI, that is wheezing associated with lower respiratory infection. Here also we will end up using antibiotics, but we should use antibiotic over here only if there is a radiological evidence of a pneumonia or raised inflammatory markers. Again, that's controversial. And for the non-specific cough, we many times are using azithromycin as an anti-inflammatory agent also. So all these practices are definitely irrational, and the consequences of it is that definitely the antimicrobial resistance is increasing and the healthcare cost also is increasing. Irrational practice number 2 is polypharmacy. So when you go to a juice center, they have this FJCs, fruit juice combinations. There is a fruit center in Borivali where I practice. He claims that he has got more than 300 fruit juice combinations. So something similar is there with the fixed drug combinations of cough syrup. There are more than 300 cough syrups available in the medical store. These are the combination of antihistaminics, decongestants, antitussives, bronchodilators, expectorants. Now each one of has, just imagine a child who walks in our OPD with fever, cough, cold, and we write this drug combination. So on an average, the child receives almost 5 medicines at a time for the simple cough, cold. Antihistaminics are not at all effective in non-allergic cough, so it's irrational. Decongestant medicines can cause hypertension and tachycardia. Antitussive medicines, especially used when it is wet cough, it will block the mucus, it will cause mucus infection and sedation. So all these medicines are irrational, and there has been a national and a global ban of this fixed drugs combination cough syrups, especially for the children below 2 years of age. So 4 medicines in one cough syrup is not 4 benefits, but we are inviting 4 more side effects. So it has to be used with a lot of caution. Then irrational practice number 3 is unnecessary nebulization. Nebulization for every simple cough. Now this has become a ritual in our patients. Most of the patients at home are having nebulization machine, and every time the child coughs, they are ready to give the nebulizer. So nebulization should not be used for every athlete choice unless there is a proper physician diagnosed wheezing. So common irrational practice includes this, that we are using nebulization for simple cough. We use nebulization, bronchodilators in bronchiolitis, again that is irrational, and the use of illegal aerosols. I cannot name what all people put in the nebulizer chamber as aerosols, but dexamethasone is also used, which is irrational, and many people even use antibiotics in pneumonias as for nebulizing the patient. So this absolutely is irrational. Now, whether to use nebulizer. So in a child who is stable, where we have wheeze, right, there is no role of nebulization. Ideally, we should use MDI with a spacer, which is equally effective. It is more hygienic and delivers a consistent dosing. So the important message is nebulization should be used only when there is a proper indication. Irrational practice number 4. steroid overuse. Now, early steroid, many times the child comes to us with mild viral wheeze, and we start this oral prednisolone, a short course, which is irrational. And many times when you prescribe this as a cough syrup to the patient takes it. Every time the child coughs, the mother starts with the child on the steroids and leads to the complication of steroids. Then unnecessary escalation of inhaled steroids. The inhaled corticosteroid also, when we start with inhaled corticosteroid, it should be the lowest possible dose which is effective. And once the child is stable for a period of 3 months, it is very important that we step down and stop once the child is cured. So steroids are powerful, but it should be used very judiciously. Now there are a lot of adjunct therapies which are also irrational. Use of Montelukast for every cough and cold is absolutely irrational. Then use of mucolytics. There are so many mucolytic drops available of ambroxol in infants. Now, what does the mucolytics do? They cause thinning of the mucus in infants, and it causes more complications in these small babies. Then use of vitamin D and zinc as a immunity drops for every cold, which is absolutely irrational. It should be used only in a child who is deficient of vitamin D. Then use of antioxidant like vitamin C for the treatment of pneumonia is irrational, and the pharmaceutical company come to us with these herbal immunostimulants for children who come to us with recurrent cough and cold. This also is irrational because almost 6 to 8 episodes of cough cold per year is normal. Then the use of these fixed drugs combinations for common cold is irrational. Only saline drops and maintaining hydration is good enough. Use of salbutamol nebulization in cases of acute bronchiolitis is irrational. A good oxygenation and hydration is good enough. Use of oral salbutamol in mild asthma is irrational. It is important that we use a short-acting SABA, with MDI with spacer. That's very important. And short course of azithromycin for 3 days in case of bacterial respiratory infection is irrational. Amoxicillin is the drug of choice. So what is the way forward? The way forward is that we should always have evidence-based prescriptions. We should practice antibiotic stewardship. No doubt in respiratory infection, we have clear-cut indications of using, say, amoxicillin for a documented case of bacterial pneumonia. And of course, the children who comes to us with a wet cough lasting for more than 4 weeks, a 2 weeks course of amoxiclav is what is recommended. We should follow the guidelines which are there. IIP National Respiratory Chapter has come up with beautiful guidelines, and it is updated regularly through this Journal of Practical Pulmonology Journal. We have the standard treatment guidelines available on the IIP website, which we can always refer, and those guidelines will help us to at least reduce the irrational practices we do, and of course the GINA guidelines. Parenting counseling is very important. We have to explain them that every cough need not be treated. We should treat those coughs only which is, thank you. I have 1 minute left. We should treat the cough only if it is causing significant discomfort to the child, and also explain them the risk-benefit ratio when you are using the cough syrup. So the best prescription is not the longest one, but the most rational one. So the conclusion is we should think viral first in pulmonology cases. We should resist our urge to cover the viral wheeze with antibiotics, and we should stop using these fixed drugs formulations at least for the children below 2 years of age. Whenever we think of using a nebulizer, always think that is it possible to use an MDI with spacer in a stable child with wheeze and avoid nebulizer. Of course, when the child comes to us in a breathless with low oxygen saturation, etc., where the oxygen-driven nebulization is indicated, we should educate the parents and explain them the importance of cough, that cough is a protective reflex and need not be treated. Thank you very much. I finished in 30 seconds in time.
One very important thing is use of Cefixime for RTI. It is very commonly used. That can never be used.
So I think to cover so many myths and misconceptions and their corrections in just 10 minutes, thank you for doing it so crisply with such hard-hitting take-home messages, sir. I invite Dr. Mukesh Sankleja, sir, to please felicitate Rajesh Kasla, sir. And there are a couple of announcements before we break for lunch. The lunch for the faculty and the organizing team is arranged on the ground floor in the activity room, and the delegates can have lunch here. And it's the same lunch, but we've just distributed it in 2 places to avoid the tea crisis like thing again. Another thing is there are some mementos. There are some mementos for the delegates from Team AIRCON which are placed near the registration desk. So please don't forget to take them before you leave. And once the conference room behind the auditorium becomes empty, there will be a second screen who will screen the radiology quiz also. So those of you who are done with it or are still waiting to solve it, around 1:40 till 2, that will be screened over there after the room is empty. But please have answers will be put after that. The quiz will be over by 2, and we'll meet again at 2 o'clock for lunch. Thank you.